Hey there.
Yeah, yep, I'm here.
You all ready?
I was in downward dog. Yeah, so I don't know how to control the slides though, how that will go.
What you do is you share your screen and then you should be able to control it.
Okay, so share
Okay.
my screen on a different screen than this one, right?
Well, there should be at the bottom there, it'll say there should be right in the center, it should have share.
Okay,
Okay.
I've clicked it and it's, I guess, deciding hold shift to select two desktops. That's two. I guess it's desktop three. Okay. Okay.
There should be a button right in the center. It says share.
Yeah, I see it, but I've got three screens, so I'm trying to make sure I'm putting the right one on.
Yeah.
And then making
I,
it like
I was never that important, so
to have three screens.
yeah.
Ah, I don't know. Either that or I'm just my brain is so scattered. I've got to have three screens. It's whatever way you want
We
to look
may
at it.
we may be having another guest.
What do you
So
mean? Oh, with Dr. Tano?
with Dr. Tano. Yeah, that
Okay.
this just happened this morning. So
Okay. Well, he had mentioned it last week.
mhm. Yeah.
Um,
So I got somebody, I have a very special guest who said she would be here, but she's pretty busy, so I don't know. We'll see.
oh, okay. I think I've okay, share. I think I've got it. Open system setting. Allow yeah, open system settings. I've got to allow it somehow. Well, that sounds exciting to have somebody special.
Yeah. So one of my
Okay.
teachers, actually. So
One of your teachers.
one of my teachers. Yeah.
Wow, she must be super duper smart.
Way smarter than me. So,
Says Zoom may not be able to record the contents of your screen until it's quit. Okay.
well, we record it. You don't have to worry about that. So
Did it share or what did I do wrong? It would come up, right? If I,
it should
uh,
come up. Yeah.
all right, one more time. So it's desktop three, and then I hit share.
There it
Zoom is
says the Four
requesting to
Sisters.
bypass the,
I
yeah,
see I see the Four Sisters.
okay. Okay, so then it's requesting to bypass system private Windows picker and directly access your screen and audio. This okay, allow.
We got some heavy hitters here tonight. It's my very special guest, other than Dr. You and Dr. Tano, who are also always special. But we got Dr. Bergson on,
Okay.
who's my one of my mentors, and Carol Peterson also. So we got some pretty good hefty hitters here. So
That's great. It'd be good to hear from them on what they think about all of this.
I know Dr. Bergson. I think we did a presentation at A4M once. Dr. Bergson, right?
I think she's muted. I think
You
you're muted.
muted.
Hi there.
There you
hi
are.
Hi,
there.
how are you doing?
Very good. It's nice to see you. You're looking so well. Nice. I
Oh
remember
yeah, you're
that.
looking well too.
Oh, thank you. Thank you. It's nice to be here. William invited me because we went West Coast swing dancing when we were at A4M,
Who
and
the
we
hell
kind
is
of
William? Nobody
So
named William. Nobody named
I
William
don't
here.
I don't remember your name being Devaki.
David Key, right. Exactly. Good for you. Thank you.
So, well,
How do
thank
you
you.
pronounce how do you
Thank
pronounce it? Benoit? Benoit?
No, Benoit.
Oh,
Benoit.
very Benoit.
Classy way.
Classy. That boy, that soft
Yeah,
accent
he's
just
got that. He's got that Minnesota accent. That's, we always kid him about it.
Yeah.
I thought it was a southern drawl, but I guess it's
All
not.
right.
From southern Minnesota, right?
Oh, okay.
So usually, so Lindsay and well, Carol, you've been here. We usually start off with Dr. Nario. Dr. Nario's sort of my right-hand man. He's been taking Dr. Andrew Weil's integrative medicine fellowship. So he gives us a brief tip of the week, so the rest of us don't have to go take it. So what I'm going to do is I'm going to aggregate all of the videos that we've done since you started this, and we'll have a whole course on our own. Right?
A whole course. I don't think that's going to be that extensive, but sure.
Well, we could take each topic and just expand on it. So
It's a good idea.
Let's make money out of it. I'm
so.
kidding.
Oh, that's a whole other good idea.
That's a whole nother idea. So while we're waiting, so Lindsay, you want to tell everybody about your what you have coming up next week?
Oh, don't say it's next week. It's about 10 days away. Give me a few more days.
Well, that's next week.
Oh my God. So, so in fact, if Carol's on, I don't see Carol though.
She's here.
Can you see her? I don't
I
see
see
her.
her. Yeah, I see her.
No.
Why
She's
am I
muted,
not?
though.
Why am I not seeing her? Hi, Carol. I'm not seeing her. Darn it.
Hi, Lindsay.
Yes.
Maybe I pop up.
Oh, there you
Hi.
are. There you are. Okay.
Yeah,
Hi,
it's-
Carol. Nice to see you.
Nice to see you too.
So, David Brownstein and myself are co-sponsoring a course called Everything Breast Cancer. And I think we need to have our heads examined. It's been a big undertaking. And so many of my patients are so browbeat by their oncologists and radiologists. I mean, they literally take their risks and tell them, if you take hormones, you're going to die. End of story. I've had 2 patients tell me that this week. It's so crazy. And we're trying to move the needle. We're really trying to help move the needle. So it's 20 hours online of CMEs, category 1, for MDs, nurse practitioners, naturopaths, and pharmacists. And we've got an incredible group of experts, including Carol, who's fantastic. So it's nice to see Carol here. And it's pretty exciting. And we've all been working quite diligently on it. And we hope that we help move the needle.
That's great.
I'm sure you always do. So
Oh, thank you. I hope so. This has been a little bit rougher than most audiences because everybody's so scared to death of standard of care and of
And patients
cancer.
are scared. There's no more vulnerable patient, right, than a cancer patient.
I know, and they keep they literally, I have patients that if they do radiation, they'll get a 3% benefit of life, and it'll be on their left side, which of course, if they live long enough, makes them at risk of heart valve cancer. And they'll literally take their hands and say, if you don't do this, you're going to die. And I hear that, in fact, I'm in a Mahjong club, and one of the women had breast cancer 10 years ago, and I've been sharing what we're doing. And she really had a low grade, and her bones are disintegrating. She looks like you could just blow her across the room. Lovely, lovely woman. And the same exact thing, she asked her gynecologist, who took her wrists in her hands and said, do not do hormones. You're going to instantly die. That's what she said. It's like the craziest thing. It's so sad.
yeah,
It's very disturbing.
we've heard it all early on in my way back when in the land far away called Wilkes-Barre, Pennsylvania. When we first got a heart surgeon at our hospital, this poor guy had a heart attack in the middle of the night and walked 4 miles in December in Northeast Pennsylvania to the hospital. And I was standing there, that the cardiologist stood over him and said, you have to have bypass surgery or you're going to die, and pointed right at him. And the guy who was crying, and he's looking at me, and what am I? I was a family doctor. What do I know? I'm not going to say anything, right? So he goes and has it done. They discharged him. I remember it was a Friday morning. They discharged him at 8:30 in the morning. I get a call from the cardiologist at noon. Well, we don't know what happened. Joe went home, opened his front door, and keeled over and died.
Just like that.
Huh? Just like that. But I guess that was acceptable. I don't know. So I always remember that. So It didn't have anything to do with hormones, but
But it's the
Same
same, it's the
concept.
same
Yeah.
concept,
Same thing.
right? Thank you for sharing. Yeah.
so
That's the most disturbing part of all of this is
yeah. And
witnessing people going through very, very scary times and getting bullied into doing something that's not
mhm.
necessarily good for
And-
them and can actually
and-
make them sicker, drive them towards
so
suffering and death.
so just we're gonna have Dr. Nario, you got your tip of the week, but first, I want to let you know, those of you that are local here in Reno, at the Atlantis this Saturday from 7 a.m. to 4 p.m. there is a conference by the Northern Nevada Endocrinology Society called Endocrinology for Non-Endocrinologists. So they did not invite me to speak, but I'm gonna be there in the crowd heckling. So anybody who's local, it was only, I think it was only $46, and I think there's some CME credits. So
And where is that?
at the Atlantis.
Okay. Yeah, I should be able to do
So-
that.
So
That'd be fun.
7 o'clock is introduction. 8 o'clock there's a lecture on thyroid. I'm wondering, Lindsay, if we're going to hear anything about iodine.
I doubt it.
I doubt it. So
Only to avoid it if you have Hashimoto's, right?
exactly.
That's what I've had lectured to me.
Yeah.
Yeah,
Okay,
that's good to go.
So
Pretty
Dr.
sure I'm-
Nario, proceed.
All right. Well, I'll let you get the people in. I'm clicking on all the
I will.
attendees.
I will.
All right, so let's start. So I think this is actually a good topic. So I want to touch up on, so in the fellowship, we touched up on bremelanotide or PT-141. So I'm sure you guys are pretty familiar with this because this is the female libido drug, or Vyleesi as they call it, or the thing you consider after sildenafil fails. So just to give you a brief intro about this, synthetic melanocortin receptor agonist is what's the function of PT-141, and it's derived from melanotin-2. So that's the bigger peptide, and they have isolated the smaller part. So we don't have the bad skin darkness when we use PT-141. So it works centrally in the brain, not peripherally, and acts on the receptor MC4. So this is the melanocortin 4 in the hypothalamus. So it does increase dopamine signaling, which is equals to sexual motivation and reward, and modulates sympathetic tone, and enhances sexual desire and arousal initiation. But the newer data, so this is what we're going to be getting today, suggest we've been thinking about this drug way too narrowly. So let's start with the first study. It's actually a combination therapy. So initially, they don't recommend for you to use PT-141 with PDE5 inhibitors. The reason for that is because of the risk of priapism. So for the ones who doesn't know, erections lasting longer than 4 hours. You don't want that. I know men like, wow, that's good. You don't want that. So now the newer trials that are running, so this is in the Journal of Urology 2004, are looking at PT-141 combined with PDE5 inhibitors in men who doesn't respond to PDE5 alone. And this makes perfect sense if you think about it. PDE5 affects peripheral nitric oxide vascular. PD-141 acts on the central melanocortin and dopamine release. So now we're treating the brain and of course, the downstairs, which shocking, I know, both do matter. Historically, we've had data suggesting meaningful response rates in sildenafil non-responders. So clinically, this shifts PT-141 from alternative therapy to adjunctive or salvage therapy. Another one, study number 2, would be FDA only approved Vyleesi for women who are with hypoactive sexual desire disorder, and they should be premenopausal. So you can't use it on postmenopausal women. Newer data, so Journal of Sexual Medicine 2024, confirm that many of us are already seeing clinically and why it should be used in men. So now they're doing studies on men, but in our integrated field, we're already doing this. But now they're actually going into the real motions of research. So PT-141, as I mentioned, enhances central arousal pathways, increases dopaminergic signaling, and maybe even improves genital blood flow. So it's not purely central, it's integrated. And here's the key insight. Some men label as erectile dysfunction don't actually have a vascular problem. It's really a motivational problem. They can perform, they're just not interested, which means we've been treating a brain issue with a blood flow drug and then wondering why it doesn't work. Third study. So this is where it gets interesting. The melanocortin system regulates appetite, energy balance, reward, and sexual behavior. PT141 is now being explored alongside metabolic therapies, including GLP-1 pathways. So now we're looking at a shared biology between hunger, dopamine, and libido, which raises the bigger question. Is low libido in some patients a reward system dysfunction, not just hormonal, not just vascular, but also neurometabolic? Possible. So the update framework is PT141 is not just a libido drug or a backup option. It's a central arousal modulator, even a combination therapy enhancer, and possibly a bridge between sexual and metabolic health, which means the future of sexual medicine may look less like urology and it looks like more of neuroscience if you look at it in a different perspective. So that's our leak of the week.
All right. Terrific.
So I'm sure you're using that, Dr. Bill, right?
Well, I've been using that for 20, I've been using these peptides for 20 years. And now all of a sudden they're the hottest people coming. You ever hear of BPC 157? Nope, never. Don't know anything about it.
Well,
Right?
you have to thank our non-medical colleagues that are promoting peptides nowadays.
Yeah, well, the problem is they can say whatever they want and there's no consequence, right?
Well, true.
Our non-medical colleagues, the ones you're thinking about, have also said things like there's no studies and there's no reason anybody should ever use pellets ever for any reason, right? And there's no studies on it. So, and I happen to be in the room with Rebecca Glazer at the moment. You know who she is, right? So
Yeah.
She's going to be speaking at our conference.
yeah. So I met her last summer.
I love her work.
Yeah, and she was like just a regular person. She wasn't like anybody important, like like Dr. Nario
Wish.
or Carol Peterson. She was like a regular person. Yeah. So I had an abstract at the Androgen Society last summer in San Francisco, which I didn't know they gave me 5 minutes and I stretched it to 7. So
You're banned.
yeah, I don't know. I didn't hear from
You're
them.
banned now.
I didn't hear from him this year, but unfortunately, during Lindsay's online conference, I'll be at AMMG live. So, and I know Dr. Nario, next week you're at A4M, correct?
Yep. So yeah, I can't heckle with you
You
for
could.
the Atlantis conference.
You could.
No,
that's right. You won't be here for the Atlantis. Yeah, that's too bad.
We'll be lecturing this week in A4M.
Yeah, that's too bad. The last time we went to one of those, it was at the Grand Sierra. Those are not Reno. That's another one of the big casinos here. It was a integrative dermatology.
That was fun.
For that one, and so the speaker was talking about I think it was melanoma, and it's linked to vitamin D, and he says so he said something to the point. Well, you need high vitamin D levels, maybe 1,000 to 2,000 units. That sounds about right. And we had just been drummed out of the AOA for being non-scientific. We figure it out to the molecule how much is the right amount with the formulas we have. They throw it. So
they're getting closer, as you can see. They're inching their way through it.
They're inching their way forward. Okay, speaking of inching our way forward, I know. So we have those of you who came in late. We have some very special guests. We have Lindsay Berkson. Who's one of my mentors, of course, Dr. Tano, who's everybody's mentor, and Carol Peterson, three leading lights in the female hormone world. And our elite speaker tonight is Jeanette Cerna, who's not spoken for us yet, and she's a little nervous, but I think she's going to be just fine. Not nervous? Good. Okay. And she's an advanced practice clinician dedicated to integrating biomedical science with principles of functional medicine. She holds a Bachelor of Science degree in cellular and developmental biology and nursing, a Master's of Science in Nursing, and an advanced fellowship in anti-aging and functional regenerative medicine through A4M. She also has a master's degree in metabolic and nutritional medicine. She began her career in pediatric neurology, God bless you, and intensive care before discovering the transformative potential of functional medicine. In 2015, she founded Hormone Harmony in Houston, Texas. She was the first nurse practitioner to open a practice exclusively dedicated to functional and regenerative medicine. She's now in Reno, Nevada. She has Cerna Personalized Care, where her clinical expertise spans hormone optimization, metabolic restoration, and the treatment of biotoxin-related illnesses. She's recognized for evidence-based compassion approach and her commitment to advancing the practice and education of functional medicine. As far as Dr. Tano, those of us, I think we all know who he is. So we're going to let you introduce yourself when you come on, Dr. Tano, okay?
Yeah, I think it's muted.
You're muted.
Right.
Muted. Yeah, I said, all right. That's
Okay.
good.
Do you need me to, if we read Dr. Tano's credentials, we're going to be here till midnight. So,
Jesus.
okay.
Well, not as long as Dr. Clearfield's, but yeah.
Me, I just pick up the pieces. That's all. Okay.
This little.
Nurse practitioner Cerna. I made the mistake of calling her doc. She's a doctor in my view anyway. So,
So Dr. Clearfield, can I say something before
sure.
Janet goes? So at one of the meetings here, there were some presentations on hormones and potential side effects and everything else. So it happened that many people are doing estrogen replacement these days. And I'm probably one of the dissenting voices to say that estrogen replacement is overrated. Maybe we should be careful trying to give women estradiol. And there was a heated argument, and that heated argument led to us thinking that we should have a round table and talk about estrogen replacement or hormone replacement. That led to this show that we're going to present today. So I'm really glad that Dr. Peterson, Dr. Berson, NP Cerna, myself, and the whole audience is here today for us to have this roundtable discussion to see what everybody is thinking. And then we'll go from there. So that's what I wanted to put in before as a prelude to what we're going to talk about.
So we're going to all gang up on you, Dr. Tano. Is that what it is?
Well, yeah, maybe.
Well, I'm on his side. I agree with you. I don't normally have to give many postmenopausal women estrogen.
Okay.
Because they can usually make it themselves through the adrenal glands and, the conversion of estrone.
So we two of us are on.
Yeah, be two
agreement.
against everybody else.
Now, everybody else who says, well, they want to do. So we have a pro and cons. We have a pro group, which will be a group of people who say we have to do it, like Dr. Zidi, I think, if she's here today. And we have ourselves who believe maybe we should not do, we should be more careful giving women estrogen.
Well, when I was going through the A4M program.
How come we can't see you? Why can't I see you? Who's speaking?
I think it's the way you have your settings.
Okay, I want to see
viewing
you.
who's
Want to see
should be
you.
in your settings.
Actually,
I see the constant
I don't
strip,
quite
but you
know
can
how
also.
Yeah, if you put your phone the other way you had it, Dr. Bergson,
there you go.
This is better.
That should be better.
Yeah, I still don't see. Okay. I don't want to bother you with it, but I'd love to see.
If you put your cursor over the picture of whoever you're seeing, and then there should be 3 dots at the top right, and that should
settings. Here's my settings. Okay.
should be in your settings how you view it. You can
Okay.
only.
Thank you.
Okay, so convince us. Go.
Well, I didn't plan this to be a convincing argument, but I think it'll happen anyway. I mean, I appreciate Dr. Tano explaining what caused us to start putting this together. And so my goal was to just go back to the real basics of of the estrogens and who they are and what they do. And then we can extrapolate on that, see what people have interpreted through it. So I guess you're looking at my first slide, right?
Yeah.
Yeah.
The four
So
sisters.
that's my parents' four girls. So that's my three sisters and me. And then we have three brothers too, so we have a big Catholic Spanish family. But so when I was in the A4M program, they harped on the three sisters, E1, E2, and E3. And then it was only recently that I heard from Dr. Smith, Pamela Smith, that there was a fourth sister, a fourth estrogen. But it was discovered quite a long time ago, so I'm not sure why it wasn't ever part of the program.
Actually, in Pisona, I did a presentation at A4M once, and I brought Estetrol to that presentation. So
Good.
I don't know where everybody was. So the original person, and I did a lengthy presentation showing what the virgins are doing to create a birth control pill based on the
Yeah.
Estetrol and all of that. So I don't know how people got it from there, but
Well, I mean, I started the program in '09.
yeah.
So that was, and I been kind of out of it for the most part since about 17 or 18.
Yeah.
So they may have changed. It was a while ago.
Mhm.
So I guess I just hit the change slide and it'll change on me. So the first estrogen of the sisters is E1, which is estrone, and it's a ketone with one hydroxyl group. And I just think that it's important to understand this part of what that hormone is because it affects how it acts in the receptor site. So in the upper left, I put in the basic structure of a ketone so that you can see it in this pretty complex sketch of the hormone. And so you can see that it has only one hydroxyl group, a phenolic hydroxyl group down on the left. Okay. And this is where they get their names from. And I don't know if everybody understands that, but I thought it was interesting. So then E2 is estradiol. So you can see again, it's got two hydroxyl groups, one on the left and one on the right, in the sketch. It's kind of an easier way to remember them too. So it's an alcohol with two hydroxyl groups. And then E3 is a estriol, so it's an alcohol with three hydroxyl groups. You can see the one, two, three. Um, and then the fourth sister is estetrol, which I have only heard about recently, and it's got, tetra, got four hydroxyl groups. You can see that um, on the slide. Um, so the hydroxyl groups of the estrogens determine their potency and function. You can see estrone has one, estradiol has two, estriol has three, and estetrol has four. And these are the groups that interact with the estrogen receptors, ER alpha and ER beta, and the GPER. In particular, it's the phenolic hydroxyl group that interacts with the receptor sites, and regulate certain, physiological processes. And so I found a cute rendition of the two receptor sites with the goal of showing you how hard it is to properly, interact with these receptor sites to get, the desired outcome. So the three-dimensional configuration of each one of those hormones interacting with these receptor sites, it's a very delicate situation. It's very easy to not get the reaction that you want from these receptor sites. We used to call it a lock and key, an A4M. Um, so then um, as an example of that is as the estrogen binds to its receptor, you can see the estrogen up on the left, and then the very complex receptor site. The receptor undergoes a conformational change and translocates to the the nucleus, where it dimerizes and binds to specific DNA sequences known as hormone response elements. So this whole mechanism is goes towards driving gene transcription. So it's a very powerful interaction. And so the reason why I bring all of this up not only is to, help it make it easy to remember the names of these three hormones, but also to show you how the shape, the three-dimensional shape of these is so powerful as to what kind of, the effect of it. And so as an example of the synthetic ones that are, created by pharmaceutical companies, is the very famous Premarin, which has, horse hormones in it. And they use conjugated estrogens, and there's 10 different kinds. And you can see down on the phenolic hydroxyl group down on the left, that's a much different interactive part of the molecule that is going to the receptor sites. And then conjugated estrogens are not the same thing as estrogen conjugates, which I think people can, pretty easily get mixed up. And, the pharmaceutical companies use it as an argument to show that they're the same thing or that they're safe. So conjugated estrogens are more stable in the body and are therefore harder to metabolize and excrete. And that's one of the reasons why they increase the risk of breast cancer and endometrial cancers, because as I'll show you how they interact with the receptor site that is more proliferative, and then with them not being able to get metabolized and excreting, it keeps driving proliferation, which increases the risk of these, specifically these two cancers. Whoops, I read it all. And then estrogen conjugates are endogenous metabolites of estrogens that can be reconverted back to estrogens. I say they serve as a recirculating reservoir for estrogen, which, Dr. Tano, this is one of the reasons why I don't think it's always necessary to give women estrogen when they're postmenopausal, because they can still make, the estrogen will allow it to serve as a circulating reservoir. So estrogen receptors act in the cell nucleus, regulating transcription of specific target genes by binding with associated DNA regulatory sequences, and both are expressed in the cardiovascular system and the central nervous system. So the estrogens binding with the receptors affecting DNA expression, they both express in the cardiovascular and the central nervous system. But then comparing the ER alpha and the ER beta, the ER alpha is the one that's defective in the very rare condition of estrogen insensity syndrome. But it's mainly, this receptor site is mainly in the mammary glands, the uterus, the ovary, thecal cells, the bone, testes, and epididymis, the stroma of the prostate, liver, and adipose tissue. And it results in enhanced proliferation of the uterus and the breast, which is why if it's overstimulated without, the beta receptor balancing it out, it can increase the risk for cancers, for hyperproliferation. So the estrogen receptor beta is mainly present in the epithelium of the prostate, the bladder, granulosa cells of the ovary, colon, adipose tissue, and immune system. And it has a more profound on the CNS and the immune system than the cardiovascular system. So like the overstimulation of the ER alpha can increase the risk of clotting also. But the ER beta does not have as strong of an effect in the cardiovascular system as compared to the estrogen receptor alpha. So estrone was the first steroid hormone to be discovered. It was discovered in 1929. It's synthesized from cholesterol in the gonads, the adrenal glands, and the adipose tissue. It's an agonist of both the ER alpha and the ER beta, estrogen receptor alpha and estrogen receptor beta. And it does not accumulate in the target tissues, which is another reason why I don't always prescribe estrogen for postmenopausal women, because estrone is not, does not accumulate. And that's the primary hormone of postmenopause. It's poorly bound to the SHBG, so again, it's excreted more easily. Sorry, I put the question mark there. I meant to go back and double check that that was the only way that it was excreted, whether it's But so it must also be excreted through the liver because enterohepatic recirculation delays the excretion of estrone and other estrogens, which is one of the reasons why we try to maximize um, the function of the intestinal system and excretion so that these hormones don't recirculate. And so estrone in high levels is associated with frailty, VTE, stroke, and cancers. And so the Premarin that's high in estrone um, increases. Those are the risks that I misspelled that one word there. Estradiol was identified in 1935 after E1 and E3 were discovered. It's also synthesized from cholesterol as a conversion from testosterone or estrone. So again, that's another reason why we don't always need to give a postmenopausal woman estradiol because they can convert it from testosterone or estrone, both of which come from the adrenal glands after menopause. Estradiol is, as you probably already know, responsible for the secondary sex characteristics in women, including the widening of hips and fat distribution. Um, you know more about, I'm sure you know the other rest of the sex characteristics in women, so I didn't put them all there. But it begins in puberty and it will eventually close the epiphyseal discs, at the end of puberty, just like testosterone does for men. So the estradiol maintains the oocytes. It enhances the growth of reproductive organs. It's produced in premenopausal women by the ovarian follicles, and it triggers the LH surge and ovulation. And then with progesterone, it works with progesterone to prepare the endometrium for implantation. It declines after menopause when it comes from, sorry, it declines after menopause and then I didn't write that sentence properly, but women can still get it derived through the adrenal glands via testosterone or from adipose tissue via estrone conversion. So I didn't write that sentence very well. But postmenopausal, the adrenal glands and adipose tissue, right, so the adrenal glands will make either testosterone or estrone, and then that can be derived to estradiol, or the adipose tissue can create estrone and then that can be converted to estradiol. In men, it's produced in the Leydig cells and Sertoli cells in pubertal boys, and in men. And I didn't keep going down that trail of how important estrogen is to men and boys, but I thought I'd just mention it. So then E3 is estriol. It was discovered in 1930. We have very high levels in pregnancy, and it's excreted very quickly in urine, so it's quite difficult to measure to see what levels a woman has, or a man for that matter, but a woman has in their body. It's the end product of E1 and E2, which is another reason why it's so safe, because it doesn't reconvert back to estrone or estradiol, and it has a preferred affinity to the estrogen receptor beta. And so estriol, it's crazy. It's not available in any manufactured forms because it can't be patented. But and there's no evidence of toxicity. You probably have heard about Wyeth Pharmaceuticals petitioning the FDA to make compounding E3 illegal. They just don't want this stuff available to people. And it can, inhibit the proliferation caused by the estrogen receptor alpha. Estriol, I use it to treat vaginal atrophy, and the subsequent UTIs. And it can also be used for vasomotor symptoms of perimenopausal and menopausal women, particularly those with breast cancer, who are, more concerned with using estradiol, which has a higher affinity of the estrogen receptor alpha and the proliferation that comes from that. Estriol protects skin from aging by improving collagen and elastin structure and increasing hyaluronic acid. So when other prescribers add the estriol, to estradiol in a cream, the Biest. I don't really ever do that. I give them estriol. I give them E3 for either vaginal atrophy if that's what's going on. Um, until their estradiol levels, the other levels pick up. And then I encourage them to use estriol on their faces because it's quite remarkable what a difference it can make on, the age consequences of hormonal depletion on a woman's face. If you want to make a patient happy, give them estriol, encourage them to put it on their face. And you can get it compounded, but Emerita has a product that you can get from Full Script. That's what I encourage them to use. I actually have it here if you want to see it. I think it's this camera. Can you focus it? So that's how I encourage women. I don't know, it's not focusing very well. Estriol A3. So then the fourth one, as the other physician who I can't see was talking about, maybe Dr. Tanner was talking about this part. So E4 estetrol was discovered in 1965 in Stockholm by this guy's name I can't pronounce. It's produced in the fetal liver during early pregnancy, and I don't think they completely understand how it's working, but the placenta is involved in the production of E4, and this is the only place E4 is made that we know of, so it's certainly not bioidentical to a man. But it's as demonstrated to be as effective as ethinyl estradiol as an oral contraceptive, but without the adverse side effects. So why we're using the other forms of birth control, oral birth control, I'm not really sure, but the FDA approved in 2021 using E4 with a progestin is a product called Nextstellis. I've never prescribed it though. I don't prescribe much of birth control pills. But so here, I'm sure you've seen this a million times, but I just wanted to remind you, because this is the direction we're going in, is the steroidal pathway of, cholesterol to the steroids. So up at the top left, you can see that it all starts from cholesterol, and it's actually LDL cholesterol. And so I guess at this point of the talk, what I'm going to sort of aim us towards is how I present this information to a patient to help them understand it at their level, so that they have a format of what I'm functioning from. And so when I show this I don't show this complicated of a slide to them, but I make a point of pointing out that it's LDL cholesterol that we get all of these hormones from. And, statins, of course, interfere with that conversion to cholesterol to pregnenolone. And then the rest of, so if somebody takes statins, they're at risk of having a decreased production of all of the down products from it. So cholesterol at the top, the first hormone that's created is pregnenolone, and I call that grandma. I make personalities out of the hormones. I think it really helps patients understand what's going on. And so we don't have to keep looking at all of these things. You can see the main products. I'll just show you so I take out a piece of paper and I actually draw these words in front of them. So I don't hand them this because I don't think that it absorbs, but I actually start with this is a steroidal family. And then I give them a moment to think about that, because they think steroids, this is a steroid, and they think about the steroids they get from their practitioner for some excessive inflammation. And I say, yeah, all your sex hormones are steroids. So they're not an unfriendly, they're not a dangerous drug. And so it starts from LDL cholesterol, and then I talk about the whole statin connection, and the first hormone is from LDL cholesterol is pregnenolone. And I'm making it very simple. There's a lot of, like you can see from the other picture, we know there's a lot of other derivations and stealing from hormones, but this is the structure I want to put in their minds. So the first hormone is pregnenolone. I call her grandma. And then I separate the catabolic and the anabolic sex hormones, so that they can understand that the goal is to balance the two, catabolic and the anabolic. And because I think that a lot of patients are focused on getting, anabolic steroids because they want to be lean and mean and have strong bones. But we need to also have catabolic hormones, or it increases our risk of cancers, right? Hyperproliferation. We need to have stuff die off. And so to the left is the catabolic hormones. So I talk about progesterone, and I'll mention how soothing it is, especially to women. It's myelinating. So I'll also say things like, so if a person is deficient in pregnenolone, and I tell them kind of what that person looks like. It's a person that tends to be it feels very unstable. They're really very uncomfortable in their bodies. And then progesterone, a woman without enough progesterone feels like they're like a raw nerve. And I get a lot of nods, because that's exactly how they feel when their progesterone levels are low. And, I say it's actually myelinating. It actually coats insulates the nerves of the central nervous system. So there's really a physiological reason for how they feel. And then I say that, especially in women, because most of my patients are women, you get cortisol from progesterone. And so if you've got a lot of stress, I talk about how you can steal the progesterone. And I say that basically, basically every woman walking down the street is deficient in progesterone because they're chronically stressed and their cortisol is chronically stealing quite readily from progesterone. And so progesterone is a lot of where I start, is supplementing that. It can really make people feel very comfortable and be safer because it counteracts the anabolic um, proliferation from the other hormones. So on the other side, on the anabolic side, I talk about, and I wrote quickly to you right in here, but so you've got the four basic anabolic hormones that are part of therapeutic care. So talking about DHEA, I call DHEA the supportive uncle because he is anabolic, so he's kind of a little bit more male. And I don't know, that's how I think of it. If a woman is stressed chronically, she'll use cortisol initially, and then it'll steal from progesterone. And then if it gets longer, she'll steal from her DHEA. And so that's why I like to measure all of these things. And I know that Dr. Clearfield measures pregnenolone right up front. I don't. I can usually look at them and see how they're acting to, it's not a bad idea to measure pregnenolone, but I don't think that it's really necessary because I can usually make them feel better by measuring what's on this, the HEA, estradiol, testosterone, and progesterone to help them feel better at first. And so one of the other things I tell them from this slide is that if the stress is really chronic, it'll eventually steal from grandma. And so if that's low, I say, well, it took us a long time to deplete pregnenolone. We're going to replete it. If you're low, we'll replete it very slowly so that it has time to go where the body needs it, down the progesterone, down the anabolic or the catabolic side. And then we'll measure it and guide it where it's going. So this is a big slide. My parents used to really, really happy about seeing this. And then, of course, they take this piece of paper home in the folder I give them. So then I don't show them the molecular structure of these three sisters, and I don't mention the E4. But I do make a separate piece of paper that's, has the E1, the E2, and the E3, and I write out their names at this point. And I just show how that E1 and E2 have a double-headed arrow. They can go back and forth. E1 can become E2 and E2 can be E1. And then you can see that those both estrone and estradiol can become E3. Estriol, but it's a down product. It doesn't estriol cannot go backwards towards estrone or estradiol, which are, potentially the less safe sisters. And I think people really, maybe especially women, just it clicks in their brain, relationships, and personalities. Certainly how I got through organic chemistry was I would come up with personalities for these chemicals and molecules and elements and stuff so that I could predict what might happen. So then again, they go home with this piece of paper. This is the three sisters, and I've got E1. I write the words out in the arrows. And then I pause and give them a little time to sort of, put it in their heads and see if they come up with any questions. And so and this is part of the narrative. So I don't write all this part out, but I say that, E1, as we all know, is the main estrogen that a woman produces after menopause. It comes primarily from the adrenal glands and from adipose tissue. But the power of this sister comes from converting to E2. And so E2 is the most powerful sister. It turns girls into women. I don't say secondary sex characteristics and all that other big words. I just, it turns girls into women. And it really affects our memory. So if our estradiol is low, we tend to lose our memory, especially for the names of things. It's one of the symptoms of a low E2. Could be other causes too, but when women can't what's the name of that? It's potentially their estradiol is low. So E2 is 10 times stronger than E1, and it's 100 times stronger than E3. It's also responsible for the sex drive in women, where, I don't know, the media talks about testosterone being responsible for the sex drive in women, and it's not really true. Testosterone converts to estradiol, and then that's what's actually responsible for the sex drive in women. So E3 is the weakest sister, but she's the most protective. So it's the very high levels of pregnancy help protect the pregnancy, and it does wonders for skin health and vaginal atrophy. So I always, as one of my questions, my 100-question questionnaire for patients come in, I ask about, the symptoms of vaginal atrophy. So if I have a woman who's either, perimenopausal or postmenopausal, and they talk about vaginal atrophy as a significant part of their experience, I will treat them with E3. I mean, I'll measure all the other stuff, but I will treat them with E3 that's compounded. I don't give them this stuff. I compound it, and they have that way they can have a little suppository. And 2 or 3 times a week, depending on how bad it is. And then I'll write prescriptions for about 3 months. And then say, just at that point, kind of use your judgment, do it 2 or 3 times a week. I mean, I'll say 2 times a week or 3 times a week based on my own assessment. So if I start somebody out 3 times a week because I think, boy, this woman is really suffering, and it could be affecting their, their intimate relationships, because it's very, and UTIs and all the other risk factors that come from it. And I'll explain that E3 actually helps regenerate the tissues down there. It's not a lube, and to make sure that there's at least 24 hours after they use it before they have any kind of intimate relationship, because even though it's a very weak estrogen, no man needs extra estrogen because it'll compete with testosterone. But so then I say just kind of use your judgment after that. You should probably take about 2 weeks before you really start feeling better down there. And then you feel like you can go, so if you really need it 3 times a week, then just keep it up. But then if you're like, okay, I can pull back to twice a week, and then eventually wean yourself off. And then at the same time, I'll be doing the work to get their estradiol up so that estradiol can convert to E3. And that should not be a problem. It should be resolved, not have to deal with it. So I have women come in crying, about how awful it is to have vaginal atrophy. And I say, I understand it's awful, but it's really pretty easy to fix. And that makes them very happy. And it really is quite easy to fix. So I think it's the end of what I wanted to share with how I treat patients, and mostly how I speak to them, and help them understand it. So then my last slide is, if anyone's familiar with these ladies from Saturday Night Live,
Yeah.
Mike Myers.
Dr. Nario wouldn't know that. He's just a baby, so he wouldn't know from
Well,
that.
he's missing out. He's got to look it up.
So I know, Dr. Tano, that you have something prepared, but Dr. Bergson's got to leave shortly. So Lindsay, do you have anything you'd like to share with us before you go? If you're there, I know you're still here. She might have fallen asleep.
Sorry, my mute. I'm really pooped. No, I thought that was really good. We all have our own viewpoints on. It's amazing how hormones really have so many viewpoints. It's just an
Wow.
extraordinary terrain. It really is. And it's great to always hear someone else's viewpoints. I appreciate that.
Well, I do
I
tell them
I
a lot
have a
that
comment.
like this model is not perfect. It just I think it's the best way to explain
Great. It's great to hear
the
how
form.
yeah,
I
great.
I have a comment.
Okay.
I look at hormones as bioneuromodulators
Okay.
for the simple reason that there are many cell groups in the brain that produce hormones. They produce particularly each of the steroids, E2, E3, all of them. And there are cell groups, neuronal groups, that also produce, I mean, not neuronal groups, but there are cells groups that produce testosterone also, and DHEA. So all the hormones available in the testes, in the ovaries, in the adrenal glands are being produced in the brain. And why that happens is that there is a bioneuroregulatory action in the brain. So hormones work as neurotransmitters and influence neurotransmitters such as serotonin, dopamine, etc. So when women go through perimenopause and menopause and they don't have enough estradiol, etc., they suffer more than physically. They don't have enough endocrine modulation in their brains. And I think we need to be more scientific in the way we replace hormones and not assume that a similar hormone is the same than estradiol. Estradiol is the most important molecule that modulates the brain in women. And if we look at the cell membrane, the cell membrane is full of steroid receptors. There are estrogen receptors, estradiol receptors, estrone, estriol, etc. But there are estradiol receptors in every single cell in the human body, from the bones to the skin to the nerves, etc. Why is that? That is the way we are made. Hormones are extremely important chemicals that bioregulate transcription of proteins.
Right.
So all the tissues are sensitive to the level of hormones. And chemically, there is a perfect geometrical shape that adapts a perfect geometrical shape between the hormone and the receptor. So there is not a similar shape. It is a perfect shape. So when the hormone, the E2, will meet the E2 receptor, the shaping of both is perfect.
Right.
And when a similar hormone meets that receptor, it's not perfect. It is somewhere, it meets the receptor, but there is not a perfect function.
You mean like a non-bioidentical one? You mean a
When
non-bioidentical?
xenoestrogen meets an estradiol receptor, a xenoestrogen is wrong. And xenoestrogen is like a free radical that is extremely dangerous because it's a cancer-causing chemical. So I think the best thing we can do for women is to cover those receptors, but by giving them exactly what they need, which are estradiol, estriol, testosterone, and progesterone, the way the human body is supposed to have, and cover those receptors with healthy steroids instead of leaving those receptors open for whatever Mother Nature can bring from the outside.
Can I ask one quick question, Dr. Zilli?
Disrupt the tissues.
How much estrogen do you think you want to give them to cover all these receptors? How much do they need?
Okay, I think after many, many years of experience, I think the middle dose for most women is 0.6 to 5 milligrams a day. But not everybody is the same.
Oral
Some
or
women need
transdermal?
less, like 0.3 milligrams of estradiol a day, 0.3 to 5. Some women need 1.25 milligrams of estradiol, but they do need the real molecule. And when you give it to them, you see that in the changes in their faces. When you see her, you see the patient 4 to 6 weeks later. They don't have hot flashes. They have more serotonin. They feel better. The osteopenia disappears in 6 months or gets improved. The progesterone is very biomodulating, especially at night, decreases anxiety, it gives a better sleep. And the testosterone is extremely important. I know that we need to make things simple, but I prefer to give them a combination of E2, E3, progesterone, testosterone. Not everybody needs testosterone, but to give, and not everybody needs progesterone, by the way. Okay, some women do very well on their own for some reason. So the best way to measure the hormones is with the saliva test or with the serum test. I don't do urinary steroids labs because it's cumbersome. But I do get guided by the symptoms, mainly by the symptoms, the clinical history, the saliva test, and the laboratory, the blood test. And so I think we need to make an effort to balance them out with the real molecules, not with similar molecules. And never, ever let just have the thought that the xenoestrogen will meet the estrogen receptors and things are going to balance out. I think that is terrifying. We need to be detoxing the patients, showing how to eat best, how to use glutathione, how to use NAD, how to improve themselves, and how to eat organic and just learn to protect themselves from xenoestrogens in the environment. But not assume that because they're postmenopausal and they're a little obese, they will have enough estrogen to survive the way they're supposed to. I think we need to do the real work and give them exactly what they need. That is my point.
So then it seems to me that I didn't make my point clearly enough about the slide I just put up. That's what I was trying to explain about how what the 3 or 4 estrogens look like and how, the shape of the receptors for it are even more complex looking and how important it is to use bioidentical hormones. But I didn't make the point about the xenoestrogens also. causing trouble in these receptor sites.
Yeah, I would address that. So
Yeah, that's
Dr.
because
Beck,
Dr. Tano said he
yeah,
would.
Dr. Bergson, they said you're going to leave. So if you could give your point of view, then we can proceed and go through this whole thing.
So what would you like me to say? Dr. Tano, by the way, it's so nice to see you.
Yeah,
I'm remembering our long talk at that A4M meeting. It's all coming back to me now.
correct. I told you we did a presentation together one time. Yes.
Well, I have very different points of view for some of the things and some overlap, and I'm really pooped. I've been talking all day, but
Well, we will have you on after your conference and after you've recovered from it, and we'll have you on more extensively. But if you have a little a short blurb, and
okay,
then we're going to
sure.
let you go. We really appreciate you being here.
So hormones are really incredible and they're not a finished science. We had the genomic signaling, which is the lock and key, and then we have the non-genomic signaling, which is transmembranous signaling, and then we have the crosstalk, which is a third mechanism of signaling, and now we have hormone signaling without a receptor, without a membrane, without crosstalk. They've discovered two of those right in the brain. So hormones just keep growing and growing and growing, and every single hormone signals in every single one of these ways. So it's extraordinary. And ER alpha is no more ER alpha anymore. It's ER alpha 66 and the shorter isomers, ER alpha 46 and 36, that completely caretake or disrupt. And there's a whole new science which we go into in everything breast cancer. In fact, we even have a picture of 17 beta diol entering a receptor, a video of it, and showing what happens on target tissue. So it's so fascinating. When I was a distinguished hormone scholar at Tulane, Tom Bishop put together these computerized videos, and it's really exciting, the expanding universe of hormones. But in the largest study ever run, the 10 million study put on by our NIH, published in April of 2024, I'm not a fan of conjugated estrogen, of Premarin, but Premarin was more protective against breast cancer than any other estrogen at all. And there was no debate about it. It was run on, there were 10 million women, and 1,500,000 women were on hormones compared to the other women. And statistically, women on estrogen replacement, some of them had progesterone, some of them didn't. They had statistically less breast cancer, colorectal cancer, and lung cancer, and then they had a non-statistical protective trend toward a reduction in many other. But as crazy as it was, even Premarin was more protective than estradiol. So just a fact that's like the largest study ever run. There were a number of issues with that study as several statisticians from the NIH put that together. But what we learned from that, up until then, we all thought, only bioidentical. I'm only into bioidentical, but we realized that almost any hormone is better than no hormone. And that was a major shockaroo. No one thought that was going to happen with Premarin. But anyway, it's really exciting, and it's an honor to be part of hormones. For years, we've been saying that hormones protect against breast cancer and protect your brain, and everyone was bad-mouthing hormones. And McCarran just discussed, our FDA head, our 28th FDA head, just wrote in his best-selling book, Blind Spot, in the second chapter, that the reason everybody thought that estrogen caused breast cancer is because June 28th, 2002, Jacques Rousseau, was the primary investigator of the Women's Health Initiative. He told all the co-authors, of which McCarran is one, we're going to put out a press release that says that estrogen causes breast cancer. And all the co-authors looked at each other and said, we didn't reach statistical significance on that, because every single analysis of the Women's Health Initiative has only shown estrogen is breast protective. First, it was a trend, and then it became statistical, and the final reanalysis was 2019. And so McCarran said, we can't do that. And he said, if you all open your mouths, your careers are ruined. And everyone shut their mouth, and that press release went out, and the whole world is so reactive The next week, the Journal of the American Medical Association published a paper saying, why did the Women's Health Initiative stop prematurely? They did not reach statistical analysis. And we have lived in a mire of lies, and our FDA head just admitted it. And that's why we're putting on the Everything Breast Cancer, because there's no data at all to support that women with breast cancer have any worsening outcomes. In fact, they have better outcomes if they take hormones. And there's 25 major studies, several of them randomized, that show, and they all have matched cohorts, that women with breast cancer do better. They have less recurrence and less risk if they do have recurrence. So if a woman is on hormones and she gets breast cancer, our message to them needs to be, you're doing better because you were on hormones. You have higher ER positive, higher PR positive, and less amplified HER2/neu. So I love being in this space. I had breast cancer 31 years ago, and I've been on hormone replacement therapy for 28 and a half years. I'm going to be 78, and I wouldn't be doing what I do today without being on that. And then I had kidney cancer because my mother took DES when she was pregnant with me, which is why I wrote that book on endocrine disruption called Hormone Deception. So this has totally been my passion, and I love to hear other people's points of view, because everybody on hormones got a point of view. I was driving home from the gym the other day, and I followed this gynecologist in Canada because I don't like anything she says, but she's got like 2 million followers. So I want to hear what she says. And she was talking with another gynecologist, and they said, what does FSH have to do with hormone replacement? And one of the gynecologists says, nothing. There's only rodent studies on it. In the first weekend in May, I'm giving the first global talk in Mexico. I'm the keynote of the huge integrative conference in Mexico about all of the human trials on FSH, and they were saying how there were no human trials. So it's so interesting that we all know what we know, and a lot of us say it, on these social media, there's so much misinformation, and women are made frightened of so many things. So it's so great to hear all these different opinions so we can understand how to help our patients, but how to keep people not afraid of hormones. I don't know why the hormone space elicits so much fear.
Knee-jerk reactions.
Yeah, is that it? Is that what it is?
Well, testosterone, high hemoglobin, blood clots, right? I mean, it's just a knee-jerk reaction,
But
without even thinking about it. It causes prostate cancer because some guy in 1941 had a patient with prostate cancer. Estrogen causes breast cancer because somebody said so somewhere along the line, and it just sticks. Right?
I love that what you're saying.
I hate to do this to you though, Lindsay.
Okay, I'm gonna go. I'm gonna go.
But
That's
before you go, you inspired me to learn about FSH, and I'm going to be presenting a short part of my talk on laboratory studies on FSH at AMMG next week. So I'm going to beat you by a couple of weeks.
Oh, that's fabulous. Good for you. There's even a range to keep breast cancer patients lower with FSH, but not as low as women who are healthy. Because as soon as FSH goes above like the mid 50s, it amplifies K167 and amplified HER2/neu, which are your major growth factors that give you an idea the woman has a more aggressive breast cancer. So it's so important, but when people don't know about something, they put it down because it's so easy to be down on what you're not up on. So it's always great to have groups that get together and share their point of view. But I wouldn't be who I am today if I hadn't been on hormones. I would be long gone. I really believe that to be true. And I'm grateful to compounding pharmacists. So grateful. I dedicated my last book that just came out 3 months ago to compounding pharmacists. And my editor said, you can't dedicate it to a field. And I went, I'm dedicating it to compounding pharmacists. So anyway, thank you. And
thank you for being with us. And
thank you.
And as you can tell, she's a lot smarter than me anyway. So I can't.
No.
My mother would be so happy if I could use some of those big words that you use. So.
Oh, do I use polysyllabic words? Okay. So blessings, everyone.
Okay.
It's so
Thank you
wonderful
so much
to
for
be
being
together.
with us.
Ciao, ciao.
So Dr.
Bye-bye.
Cano, we didn't mean to sort of bypass you here. So
No, that's okay. That's really great. I think the discussion is nice. Now we can all go back to research boards and try to figure out what is going on. Because it appears that the jury is still out. No matter what we do, we have no consensus here about whether we should give estrogen, we shouldn't give estrogen. It doesn't really matter because people will get the cancer or don't get the cancer because of the estrogen. So we have to figure out what is causing the cancer. So where I'm coming from is from the CDC fourth report. And I want to share my screen before we lose it. CDC fourth report, okay. Continue. Oh, you have to share.
stop yours,
Janet.
Jeanette.
Oh, okay.
Stop yours. There you go.
So I can give you the backstory of this a little bit. Everybody sees my screen now?
Yeah. Environmental toxins. Yeah.
So 2009, I was actually questioning why we have obesity. Because I was looking at the obesity maps and I found out that the Midwest, so from the upper Midwest all the way to the Mississippi and Bayman states, they have more obesity than anybody else. And then it goes east and goes west. So I was questioning why the people in the Middle America have more obesity. Also, I found out that Mississippi is the driver every single year. So it starts Mississippi, Alabama, Louisiana, Kentucky, West Virginia, Ohio, and then goes upward like a tree. So then it dawned on me that people in Middle America actually produce all our food for us, and they spray a lot of chemicals, pesticides, herbicides, fungicides, fertilizers, name it. When I found that, I said, well, could it simply be that the pesticides and herbicides that they're spraying is causing the obesity? Now, then I went to the rabbit hole to try to look it up. I have obesity maps, but I did not have pesticide maps. So I said, well, let me find pesticide maps. So I called the whole United States, and finally somebody in Washington, D.C. said, yeah, we have pesticide maps. So I got the pesticide maps year by year and matched them with the obesity maps, and they matched perfectly well. When I found that, I was quite excited. I thought, well, I discovered something. It looks like the areas with the heaviest pesticide spray correspond to the heaviest obesity, heaviest diabetes, heaviest heart disease, heaviest cancer rates, heaviest mortality, period. The question next came to me. I said, well, does the government know about that? And when I was digging, I found that the CDC actually has been ahead of me for years, because in 2001, they proceeded to measure these chemicals in our blood and urine, and they call it biomonitoring. So they're monitoring us, they're taking samples of individuals, their blood, their urine, and try to see what they will find. And everybody they tested actually has chemicals in them. Now, we found that the children even have chemicals when they're born. Many of them, they have like over 280 chemicals in their cord blood. So it's not surprising that when you go to St. Jude website, you see all these babies, 3 months old, 6 months old, they have brain cancer. You wonder why a 6 months old or 3 months old will have brain cancer, because they're contaminated when they came in. But the CDC, since 2001, finding these chemicals in you and I, said, well, don't worry, don't panic, we don't know. We don't know what they're doing. My question is, when are we going to worry? When we all got cancer and died? Because we know that these chemicals through epigenetics and everything else, they're causing cancer. So when I looked, I found the CDC fourth report, because they did report 1, 2, 3, 4. When they got to the fourth one, they stopped. And every couple of years, they amend it. And the chemical list is getting longer and longer. Yet conclusion has always been, don't panic, don't worry. But don't say that we should do something about it, but they're observing it still. So I went to the CDC website and I looked at the chemicals that they're finding in our blood and urine to see what they're doing exactly. And I found out many of the chemicals actually are thyroid disruptors. So that's why if you look around, we have so many women who have hypothyroidism. They do have Hashimoto's thyroiditis. They have Graves' disease. They have thyroid nodules, thyroid cancer, name it. You go to Facebook, the women are congregating there trying to figure out why they're having so much of these cancer problems. But the majority of the chemicals that I looked at, they all mimic estrogen. So if you take all your bisphenol A, you take all your phthalates, you take all of your PCBs, you take all your dioxins, all of those chemicals mimic estrogen. Well, when they say mimic estrogen, what does that mean? Well, when we talk about estradiol, actually it's the 17-beta estradiol. Now, when people did studies on these estrogens, they found out that the chemicals that we're finding in our blood and urine, they act like the 17-beta estradiol. So that means they can occupy the estrogen receptors alpha and beta that Janet was talking about, and then they can induce even more production of estrogens in the cells. So as a result, we have a major problem going with the xenoestrogen, as we call them, because they're man-made industrial estrogens and things that we're using in the farms and everywhere else. On top of that, we have the metaestrogen, all the metals, mercury, cadmium, lead, all of those things, arsenic, they all mimic estrogen. So we have the metalloestrogens that go along with that. And if you look here, we have so many of these estrogen. Then we have the organophosphates that are acetylcholinesterase inhibitors. So they make acetylcholine available. But my concern here is not those guys. My concern is the xenoestrogen that we see around. So if you see, you come here, these big groups, they all mimic estrogen. And it's not a couple hundred, it's thousands and thousands of these. Now, to make matters worse, in 1994-96, we introduced in our food chain one of the worst estrogen compound known to men. How many of you know what it was?
Is that glyphosate?
Glyphosate. We introduced glyphosate in our food chain in the form of the GMOs, because these GMOs, they don't grow unless they have glyphosate around or Roundup. Now, since they brought it in, studies after studies have shown that when they grow back with breast cells, they grow like wildfire. So glyphosate is actually carcinogen, and it can cause breast cancer. But these estrogen overall, they cause 7 cancers in women: breast, uterine, ovarian, vaginal, cervical, colon cancer, and lung cancer for women who never smoked, but also for men, prostate cancer, colon cancer, and lung cancer. Whether it is the xenoestrogens and other estrogen doing it, or estradiol doing it, but because these guys, they mimic the 17-beta estradiol, let's go down and try to see what this estradiol does. In general, estradiol and E1, so E2 and E1 interconvert, right? That's what Jeanette was saying. But interconvert through an enzyme called the 16-beta hydroxysteroid dehydrogenase. So they have 2 versions of those enzymes, the dehydrogenase 1 and the HSB dehydrogenase 2. The 2 converts the estradiol to the estrone, and the 1 converts the estrone to the estradiol. So they interconvert in the body. Now, the estrone can go to 2-hydroxyestrone and also can go to 16-alpha hydroxyestrone. Those of you who have done a lot of this work, we know that these metabolites actually are not benign, because the 2-hydroxyestrone is supposed to be protective because it does not cause a cellular growth or anything like that. It can be excreted easily. But the 16-alpha hydroxyestrone is the one that is involved in the cancer. That's what everybody says. And we agree with that. If we don't agree, now that Dr. Bergson and other people are saying there's different ways and they don't cause cancer, etc., That's why I was initially saying perhaps we have to go to the drawing board and try to learn more about all these hormones, because it's like we're back to square one. We don't know anything about them. We need to go learn about their receptors. But all the papers that have been written say that the 16 alpha hydroxyestrogen is no good. So if the 17 beta estradiol converts to estrone, and the estrone can go to 16 alpha hydroxyestrogen and cause cancer, and knowing that we have these xenoestrogens that mimic the 17 beta estradiol, that means they can induce conversion to the 16 alpha that leads to the cancer. That's the case, then perhaps estrogens are not benign. Or the xenoestrogens are not benign. They're not just there and they're not doing anything. They're doing something. As a matter of fact, if we look at what is happening to young women before Roundup was put in our food chain, you hardly will hear that young women that will get breast cancer at age 20 or 20 or 19, etc. But now we're seeing young women in their 20s getting breast cancer. Not only that, if you look at the things that feed growth that Jeanette said about, the growth of the breast, or growth of hips, or growth of uterus, or growth of ovaries, what we call polycystic ovaries, is getting younger and younger. Young girls, 14-year-olds, 15-year-olds, 13-year-olds, they're having polycystic ovaries. Why? Because of the estrogen. We know without a doubt that the estrogens are driving these growths. Now, whether it's estradiol or any other things, but I'm thinking the xenoestrogens are doing it. Do you guys know why, or when people started telling us not to drink out of plastic bottles, not to heat plastic, not to do that, not to this? How many of you know why people came up with these ideas? When did they start telling us not to drink out of plastic bottles, not to eat plastic, and etc.?
BPA.
Yeah, bisphenol A.
Early 2000s.
Yeah, early 2000, they found out young girls, some of them are getting their period by age 7.
Yep.
So precocious puberty. And all of a sudden, people think, oh, what is causing this precocious puberty? They say, well, estrogen. Well, what is the estrogen? Oh, it's plastic, BPA. And so they tell us not to drink out of plastic, not to do that. And we're making a big fuss about plastics when we have other major estrogens in our food chain. For instance, glyphosate that nobody's talking about. They're not even questioning that these things cause problem at all. For me, it's really important that we realize that these xenoestrogens are not benign. They're doing something, they're causing cancer, they're causing other havoc on the human body that we need to understand and then take better care of it. For me, when patients come, I tell them, you know what? Estrogens are problematic. And the estrogen that we have in our body here is not only the one you're making, especially if you're menopausal, probably you're making minimal E2, but through the E1, you interconvert to the E2. So there's no point in me giving you more estrogen because you already have plenty, including all the ones causing you to be obese. So then perhaps we should not add any more estrogen to you. And that's where I come from. This is my go-to table, the CDC-4 report that I always show to people that this is what they're finding in your body. If the government is saying it, maybe it's 10 times, 20 times more than what they're showing us. Maybe we all have, that's why we have this obesity pandemic. For instance, if you look at diagrams, I have diagrams, you can see that obesity was going up slowly. In 1997, it went up exponentially worldwide, and it's not coming down. It keeps on going. Why? Because 1994, 96, when we introduced Roundup, that I think led to insulin increasing worldwide because Roundup is the major herbicide that we use worldwide. The major one. You go to any boondocks in Africa, you find Roundup. Since they've been doing that, then obesity all of a sudden is spreading like wildfire worldwide. According to the World Health Organization, by 2025, last year, if we did not do anything, which we didn't do, there will be 2.7 billion people overweight worldwide. Now thinking we did not do anything to make it go down, perhaps we'll have maybe 3 billion people overweight worldwide. And nobody is talking about that. So we have a pandemic on our hand, and we have to figure out why we have this pandemic. I think that the xenoestrogen, and not only the xenoestrogen, the phytoestrogens also are contributing to it. Because we all know soy is a big estrogen. It has 3 ingredients that are estrogenic. We have a genisine, daidsin, and other component, but soy is the number 2 GMO in the country. So if a soy is a GMO, that means it has a lot of estrogen in it due to the glyphosate. And since soy is by itself estrogenic, then soy is not a good food that we should consume on a daily basis, if you ask me. They did some studies using soy, so maybe it would occupy all the estrogen receptors, and nobody will have any problems. But I doubt that would be the case, because the soy, many people who eat it in my clinic as an allergist and immunologist, I see that all the time. Women come. I went on high protein diet, and I was eating tofu and all this soy protein, and now I have hives. When I stopped, my hives went away. So why am I having hives? I said, well, it's your soy protein that caused it. It's not because your hives fell from the sky, because the estrogen, they have receptors on your allergy cells. So there's an immune component to the estrogen. When they're attached to the receptor alpha on the mast cells and basophils, they cause histamine and leukotriene release, just like pollen averfins would, that they make the effect of IgE stronger. So if people have small allergens that were not causing trouble for them, now that they have plenty of estrogen around, a lot of people are reacting. It's a lot of women. I see hives every single day. I see mast cell activation syndrome every single day. So what is activating the mast cells, if you ask me, the xenoestrogens and probably the estrogen that women are making endogenously that is driving all these reactions. So saying that estrogen is good and we need to replace it, my contention is we already have plenty in our body, and it's showing in our bodies in terms of obesity. Because when the estrogens go up, they make the insulin go up. Then people crave sweet, or if inadvertently they eat sugar-containing things, the blood sugars go up and the insulin takes it and puts it into fat cells. So all of a sudden, everybody's ballooning. And when Roundup came in, it made things go overboard, and everybody's ballooning. We cannot find the cure for obesity. No matter what we do the GLP-1s and stuff like that, agonists. But when we give it to them, even that, they lose weight. And if they don't detoxify, they gain the whole weight back. And nobody's telling them about detox. So if we still have a toxin that is estrogenic and driving the insulin, then the insulin is causing the havoc on the body in terms of obesity. And when we have obesity, we have aromatase that is produced. Now that aromatase is very important because the aromatase is going to convert the testosterone to estrogen. There are some areas in the ovary, we have 2 cells. What are the 2 major cells that we have in the ovaries? Anybody knows that cause the hormone modulation and hormone production and everything else? We have the theca cells and we have the granulosa cells, right? So the theca cells, they have LH, and the granulosa cells, I think they have FSH. Now, when we have polycystic ovaries, how do we know without doing ultrasound, etc., that someone may have polycystic ovary by doing the lab? What lab?
Without a lab? Is that what you asked?
No, without doing just checking by lab without doing ultrasound or anything of that nature. How do we know?
High testosterone?
Testosterone
and like periods that are missed. Yeah.
If I have androgens, etc. But polycystic ovaries, if you look at the LH and FSH ratio, if it's greater than 3, that is probably polycystic ovaries until proven otherwise. That means they're making more androgens than not. So in essence, the cells themselves in the ovaries, they're doing something based probably due to the xenoestrogens and thyroestrogen that we see around, because it's causing them to produce more androgens for some of these women. And also some of the xenoestrogen, some of the chemicals that we have, they also are aromatase boosters, such as anybody knows one chemical that we use as a herbicide that is an aromatase booster. Atrazine. Atrazine is a big aromatase booster. That's why it converts some male frogs into female frogs, basically, because they lay eggs. So if some of these chemicals that we spraying or we using in our daily lives, or we ingesting them or drinking through the water system, they are causing conversion of testosterone to estrogens, then we're going to have a lot of estrogen around. It's not only the xenoestrogen that we see, but we have more estrogen. So why then add more estrogen to any person? Why add more estrogen to any woman? Because they're already having, it's showing by obesity and by all the other reaction that they have in terms of mast cell activation syndrome, hives, interstitial cystitis, all of those things that are estrogen driven, they're going up if you look at it. And cancers, the different cancer that the women are having that are estrogenic, men too, prostate cancer, colon cancer, lung cancer that are estrogenic. So why then add any estrogen to anybody?
Right.
That is my contention. So I think, I'm not going to drag it along. I think other people can intervene. If you have questions or inputs and you want to prove me wrong, then you have to let me know how we can sort out this system here.
Dr. Tano, I have one quick question. Do xenoestrogens bind preferentially to our own estrogens to receptor sites?
Yeah, they do. So they do bind to the 17 beta estradiol sites, which would be the estrogen receptor alpha and beta.
Right, but more preferentially than bioidentical estrogen.
Ooh.
Correct, yeah. But the endogenous estrogen, yes.
So they bind more and more
They bind to the
readily.
receptors, yes.
Okay, so all right. So you can't saturate your estrogen receptor sites with good estrogen to
Yeah,
stop.
you can't. You cannot saturate the estrogen receptor site with good estrogen, thinking that you're going to antagonize your xenoestrogens or thyroestrogens.
Okay, and I know someone asked in the chat. I'll just answer quickly about as we all know that do anything with environmental medicine or toxicity, the first rule is avoidance. When you're talking about BTEX and you're talking about the internal combustion engine and petrochemicals, one of the best ways to try to eliminate that, if you can, is to stay out of parking structures.
Right.
Walk.
Right. Yeah. So definitely, I really think the estrogen equation probably we haven't mastered it yet. And therefore, we should be cautious or err on the side of caution than cavalierly go and say, hey, men, they can have estradiol as much as they want. Some people are giving them testosterone. So as long as the estrogen is 200, whatever, we don't care. Well, we have to care because these people may have some adverse events. It could cause many, many problems that we don't even know about.
So
What
the
is
bottom
your opinion
line,
on testing?
This one?
Your opinion on testing, hormone testing.
Yeah, so for hormone testing, I really prefer the blood test. I don't like urine test like Jeanette said, because the urine test, I tried it several times. It gave me false results. I really don't like that. So I don't do any urine test like the Dutch test and all of that. I have never done them before. I used to do one, I can say because we're not doing CME, are we? So I used to do Genova. Genova had a blood test that offered the estrogen metabolites, the 2-hydroxyestrone and the 16-alpha hydroxyestrone
in the blood.
But as of May 2021, they stopped that. They don't do that anymore. But I continue to use the blood test, which is hormone health test kit for women and for men. They do both. And that's what I have been doing for years.
And that's for the metabolites or just serum?
That's the basic hormone testing like
Okay.
progesterone, testosterone,
Okay.
DHEA, and all that. They used to give the metabolites, but I was thinking we should all gang on them and say, hey, bring it back.
Yeah, aren't we really concerned about the metabolites?
We are concerned about the metabolites, but they replace it with a urine test that is not quite as good as the blood one.
And how do you know that? Like, how did you figure out that the urine metabolite test is not as good as the blood?
Because I tried it. I tried it on several patients, and the results are really useless. So I look at the result that they have from the urine, and it doesn't match anywhere near what we had with the blood test. Same people, I mean, same women who came to me who had a blood test for the metabolites. I did the urine test on them because every year I repeat that test, and it turns out that it doesn't give me what I wanted.
Well, I've found some credibility to those urine metabolite tests. I kind of routinely check my female patients who are over 40 for their urine metabolites, regardless of whether or not they're on BHRT. And I recently had, it's been a couple years, but I had a patient who I would test her every 3 years and she was always fine. And then she got not quite grade 1, but the hyperplasia, atypical hyperplasia that was, and so I tested her again, and all of the hormones were abnormal. And so what we did was do all the usual things that I was taught to bring them back to normal metabolites. Of course, and I guess at that point she was on estrogen. So she went off of the estrogen, would clean up all her metabolic pathways, and then she had a repeat D&C about 5 or 6 months later, and it was completely, absolutely normal. And
So
then her urine metabolites were normal.
Which did you use, the Dutch test, or which one did you use?
ZRT.
You did the ZRT test, okay.
Yeah, and that was kind of like the big stamp for me to actually have a patient. I've tested her several times, and then she got the, uterine lining hyperplasia with atypia. The physicians wanted to take all her insides out. I mean, all her girl parts out, and instead she did everything to clean up the pathways, tons of supplements, tons of crustaceous vegetables. Yeah, she got a doctor to do a repeat D&C, and it was completely clear. And she
Did you give them DIM or I3C or any of those things?
Yeah, that also. Yep.
Some
And
people, they give a
yeah.
DIM I3C, but if you do that, you have to make sure you repeat the metabolites, because sometimes the diindolylmethane has a paradoxical effect of reducing the 2-hydroxyestrone, which is protective.
Oh, I think I just gave her DIM. I'd have to go look back because I haven't used the Inderal, the other stuff in a long time.
Yeah, so you have to look at the 2:16 ratio when you do those tests and see if it is high, then that's okay. But if it's low, that means your extra 16 alpha is higher. And many times, if you do give them DIM or even I3C, paradoxically will reduce the 2-hydroxyestrone. And so I expose them more to things. But if your 2-hydroxyestrone is too high, that also can lead to osteoporosis. So that means everything is a balance.
Yeah, and she's been tested multiple times since then and been totally fine. So I guess I put some credibility to those urine metabolite tests, and like you're saying, it doesn't seem like we have anything else to go by.
There is nothing else that we have. I really wish the blood test would come back because I loved it. So, I mean, that's my position, saying that estrogens are actually not our friends. And therefore, knowing that I think they cause cancer, but Dr. Bergson seems to think that no, actually, Premarin was better because when they did the Women Health Initiative trial, the reason they stopped it earlier because some people had developed tumors and whatever else. But I don't
Right.
know follow-up what the million people study that you referred to. I don't know what the calculations and how all that is
Right.
stuff, and estrogen is so great, we should use estrogen. I personally, I'm not going to give any estrogen to women. And by the way, women who show up with hot flashes, if we give them progesterone, right, they do better on the
Yep.
progesterone, the hot flashes go away.
Yeah,
So,
it helps clear out the recirculating estrogens.
correct. Yeah,
Yeah, makes me
I
safer too.
I
Yep.
I'm safe with the progesterone,
Yep.
and I give it to women all the time, but I don't give them any estrogen unless absolutely necessary.
Yeah, I agree.
If they're thin and they're complaining of
Right.
heart flashes, I give them things it's not working. Then I give them minimal estrogen,
Yeah.
1 milligram of biased, which would be estradiol 20% and estriol 80%. That's what I include in the cream, and I give it to them, and they do really well.
Yep.
So I'm not going to go overboard and give tons of estrogen to any woman, thinking that estrogen is going to saturate their receptors and cause them to balance their xenoestrogen and things like that. No, I don't think that would be a wise idea, given what we know.
Yeah. I agree with you.
Dr. Clearfield,
Yes.
your thoughts?
I'm just listening at the moment. I'm sort of in the middle of the road camp here. We have been conditioned over the past 20 years to be very cautious with estrogen, and that hasn't changed much, except for the fact that we get to say that we told you so. We've been telling you so over the last 20 years, and as you know, we've gotten drummed out of many medical societies because of it. And turns out that we were on the right track. I'm not quite as radical as Dr. Tano as far as, almost never estrogen. But
I didn't say almost never. I said some people.
I
they
said
need
almost never. I said
Yeah,
almost,
okay,
almost
good.
never. There's a lot
Almost
of
never, yeah.
there's a lot of wiggle room in there.
That's right.
But I've been a big proponent of progesterone for a long time. And again,
Right.
the natural progesterone so some of you have heard, my talks, and Carol's the real expert. Dr. Carol Peterson is the real expert on it. Knee-jerk reaction. You had a hysterectomy, you don't need progesterone. I mean, I have medical students coming in here now that they're still taught that.
Yeah.
And it's just absurd. I hand them a two slide conclusion with 142 references, and the gynecologists tell them, we don't care. The answer I get is, I'm a board certified gynecologist. You don't know anything.
Right.
So that's why I'm certainly looking forward to this Saturday's endocrinology for the non-endocrinologist. I'm sure we're going to hear all sorts of wisdom from these folks. Yes, Carol.
I have a question and something to say about the question. Total estrogens, do you ever measure that in serum and find out that it's quite a lot higher than estrone and estradiol?
I do.
I don't measure it. It sometimes shows up on its own.
Yeah.
I never ask for it, but it'll show up, and I'll get an estradiol and a total estrogens. But I'm assuming it's got estriol in there also. And
it may have xenoestrogens. I don't know. I even called the lab and they don't know what they're measuring, what is collective in that measurement, but sometimes I see it a lot higher. And then, have you heard of Plechner's syndrome? Al Plechner, the vet?
No.
Never heard of.
That's why we're here.
Okay, so he measured, and he did this on pets, but he did this on humans. They're pet owners too, about 2,000 humans. So he would measure total estrogens and he would measure, and it would be high, and immunoglobulins would be low, beta cells would be low. And these were involved with some serious chronic things. He reversed some blindness in dogs with this. And the treatment was cortisol.
Wow.
Hydrocortisone. It brought the estrogens down and it improved the beta cells and the immunoglobulins. Pretty interesting. But when I asked, like, what's in that total estrogens, his theory was that there's some adrenal estrogens that we have never even identified yet contributing to that.
Interesting.
Dr. Tano, what are we looking at here?
Oh, so I created a course, 90 hours on xenoestrogen, hormone imbalance, and chronic diseases.
90 hours?
90 hours.
Holy,
90?
90,
holy
90.
cow.
Yeah, so
I hate to break this to you, but I don't have that type of attention span
Time.
anymore.
yeah. So like for instance, one of them here, very, I mean, if it will come up, I don't know. But it goes through all the steroidogenesis and all of that and explain everything for you step by step.
Imagine a single molecule,
Yeah,
cholesterol,
yeah.
serving as the primordial clay from which the very essence
gives
of
you all the
biological
enzymes.
femininity, bone density, cardiovascular health, and cognitive resilience is sculpted.
Right.
We often speak of estrogen as a singular entity, yet in the human laboratory, it is a trinity. Estrone, E1, the steady matron of menopause. Estradiol, E2, the potent queen of the reproductive
I'm
years.
not going to play all of it.
And
but,
estriol,
it
E3,
goes
the gentle
through
protector of
all
pregnancy.
of that. It talks about the
Understanding
beta
their
cells.
biosynthesis
about
is not merely an
the
exercise in
beta cells.
memorizing enzymes.
Just about
It is the key to
conversion
unlocking the
of
mysteries of
E1
endocrine
to
disorders,
E1 and vice versa.
oncogenesis,
It talks
and life
about
cycle
everything.
transitions. In this masterclass, we will journey through the steroidogenic cascades of the ovaries, adrenals, and placenta. We will explore the two-cell, two-gonadotropin model that governs the follicular phase and dive deep into the mechanism of aromatase, the molecular bridge that crosses the chasm from androgens to estrogens. By the end of this lesson, you will possess a sophisticated understanding of how the body delicately balances these potent ligands and how dysregulation leads to the diverse pathologies we encounter in clinical practice.
Anyway,
Analyze the sequential enzymatic steps of the steroidogenic pathway from cholesterol to the three primary estrogens. Evaluate the two-cell, two-gonadotropin hypothesis and its role in compartmentalized biosynthesis within the Graafian follicle.
I think I will stop it here. So at least you will see, I mean, those of you who are interested and you want to know more about this course, let me know.
Got a life of its own.
Yeah, it's a lot of information that I gathered through all of these things that I've been doing. And hopefully it will enlighten a lot of people about the estrogens. It talks about all the receptors, anything you want to know about estrogen.
So I have a question about your xenoestrogens. How do you measure them? Is there a way to measure them?
Oh, no, because they're lipophilic in the fat cells. It's only, I mean, you do other measures, for instance, insulin. If the insulin is going up, you know, they have too much estrogen in them, and if they have too much xenoestrogen, but you cannot measure them per se. Also, sometimes the 16-alpha hydroxyestrone, it goes up tremendously if you have too much of xenoestrogen in you. And I see that not only in menopausal women, but I see that in young women as well. The 16-alpha is off chart.
And then how do you detox them?
Oh,
Or
I
do-
do the detox. I give them, Ortho Molecular has a detox product called Core Restore.
Yep,
I do
that's what
the
I
Core
use.
Restore 7-day or 14-day detox.
Yep.
Pure Encapsulations has HM complex for heavy metal detox, but also they have a detox pure pack that I give to the patients all the time. But it's not a quick detox like Core Restore. So I tell them to take it for a long time, to take it like a whole year. Then they probably can do a little bit. But all of you, you know that is coming. They have the therapeutic plasma exchange. And the therapeutic plasma exchange, for those of you who are interested and can afford it, because it's quite pricey now, uh, I think they test you first. They look at all your heavy metals and everything else you have in your body in terms of toxins, and then they start detoxifying you by cleaning your plasma. And after 5 sessions or so, they can show you that all the things that were in your blood have gone away, including infections such as latent infection, EBVs, and everything else goes away.
So I'm glad you mentioned Corastore because that's one of my favorite products.
Right,
What I really like about it is it's the only product I've found on the market that puts you through phase 2
right,
detoxification before phase 1, so that you're
right,
basically emptying the garbage can before
right,
you go in deeper to get more of the trash out. So every day that the patient's on it, they just feel better and better because they're really getting, all the crappy intermediaries and then going
correct.
in deeper. And so I mean, so if somebody looks toxic to me, or, in ways that you're talking about, it's one of the first things I like to do. And I like to have them fast for 2 days if it's possible, if they have enough glycemic control to do that.
Right,
And then do it really for 2 weeks, and what I say is 90% is an A. So they don't have to be, because like when somebody's really toxic and unstable, it's really hard to do all the things you need to do for the detox. So like they're supposed to go without anything, any kind of potentially allergenic foods like fish and eggs and milk and wheat. And that can be really a big challenge for people. They'll say, well, I just need my coffee in the morning. They should really go without caffeine or alcohol or sugar. But if they could, if there's, to do it properly, but if they just really need their coffee in the morning, I'll just say, then just have your coffee in the morning and don't worry about it. And then if you can remove all the wheat and the sugar and the alcohol and all those other allergens and like just go for it. And then every time that they do it, they become more in control of their cravings. And so each time that they do it, it becomes easier and easier. And
correct.
detox. So like when I was going through the metabolic nutritional, the second masters that I have, um, in the back of my mind, I was like, what can we do that can actually harm somebody? And what I came up with is estrogen and detox. And so those are the two things that I came up with that we can do that can actually harm a patient. And so, so that was my electives was in pediatrics and in detoxification. And so, detox needs to be done in pulses, and it needs to, you need to respect your body, and there's no in doing it. So there's not good if a patient feels bad and they're going through detox. There's no, gritting your teeth and getting through it. If you really feel crappy, really feel bad, then just back off and you'll get that bad guy next time kind of thing. But I really love Corastore because it,
Yeah. So I in my case, I give them estrogen-free lifestyle. By the way, I have written a
yeah,
couple of books on estrogen-free lifestyle, meaning if you already have estrogen overload, you're obese, you want to lose weight, why would you want to add more estrogen that would make your insulin go up and cause you to continue doing what you're doing? So I gave them a whole list of things that are estrogenic, and I said, don't touch them. And don't do these things, and including all your glyphosate-laden foods, such as your gluten, because of the pre-harvest Roundup spray that we spray on our wheat and barley. And so they do that to probably over 70 different crops now that will be spray Roundup before they harvest it. But many people are not aware of that. And so we keep on eating the same thing that causes trouble for us. I'm telling people grains are not your friend. Maybe let's stay away from the grains altogether. Or sometimes I said, if you want to have a grain at all, probably organic rice may be okay. Organic quinoa would be okay. You can do this type of grains, but no other grains that will help you lose your weight. So I have the estrogen-free lifestyle that I distribute to my patients every single day because of what I know.
Workout today is all about the hybrid, the energy high and really.
Can't hear you.
that may have been an accident.
Yeah, could be. Dr. Peterson, what is your take on all of this stuff?
Lisa is young.
Oh,
You're
and
autistic.
as far as estrogen, I'm cautious with estrogen.
Sure,
Okay.
But it's still going. Is that your slides? Dr.
Yeah.
Tan?
Yeah, yeah.
No, that's somebody in the background.
Somebody in the background talking.
Okay. Okay,
Yeah, voting.
I'm cautious with estrogen because almost everybody I see is estrogen dominant. But
Right.
if vaginal tissue is atrophying, definitely estrogen's needed. I like what Jeanette, what you said about using the
Estriol, yeah.
topical or estriol suppositories to help clear up that tissue, but it basically is a whole body estrogen issue, and you're using estradiol, and I think you said to address the full body deficiency. So I use that
They're
as a big
often
one.
deficient in estradiol. If they have
Yeah,
vaginal atrophy, they tend to be deficient in estradiol. So I just use the
yes,
estriol to help them out until we either clean them up or do whatever needs to be done to get their estradiol to a level where, it can produce enough estriol and preserve and protect the vaginal tissues after that as a down product.
Somebody
yeah,
asked for
that's,
dosing. I personally use 1.25 milligram of estriol suppository, and it has done great for women in terms of vaginal dryness and everything else. And they use as needed, like Jeanette was saying. They use it for like a week or 2 weeks. When everything is nice, they can stop it and they can reuse it whenever they want. It's not
I
like
just
you
use
have to
half a
be
milligram. I've been using half a milligram. It works great.
right.
Less better, right?
Questions? Anybody else?
I don't know. I think this is a good start for like
Yep.
a lot of conversations that we can go down.
I'm hoping you like this forum rather than just a straight lecture, just to
Right.
I
Mhm.
did.
The
It's very
discussion, I personally like the discussions and people's opinions. That way, we're all thinking and see what can we do next.
Mhm. Okay,
Mhm.
so
great.
how can we I would have a question how we can help with the obesity
Oh,
because of
so when people start losing weight, you want to make sure they detoxify because the reason they
Yes.
gain all the weight back
Yeah,
is because when the chemicals that are in the fat cells come in the blood, they tend to make the insulin go up. And so when the insulin goes up, that's when they crave sweet. And some of them, they will tell you, I'm craving sweet. I don't know why. And then if you detoxify them, then they can continue losing the weight. Otherwise, they hit the plateau and they go the other way. They keep on gaining the whole weight. But even people who do lap bands and bypass surgeries, they tend to gain the whole weight back if they don't do detoxification.
wow because of fatty liver probably the liver is toxic too
yeah,
so
Yeah.
Yeah, one of the theories they taught us, or one of the statements they said, was that the solution to pollution is dilution. So one of the big theories of obesity is that we're so full of pollution of toxic chemicals in us that our body's trying to save itself, and so it gains weight so that it can dilute it. So I totally agree with Dr. Tano that one of the early steps in helping somebody out lose weight is to slowly detoxify themselves.
and detoxification it's made with an acetylcysteine milk thistle
Now, those yeah, we have the Detox Pure Pack, which is a pure encapsulation product. You
Mhm.
have also HM Complex, which is heavy metal detox.
Mm.
You have Core Restore. You have the Eco Nutrients by Dr. Isaac Elias, who does a glypho detox. So detoxify the glyphosate. He's the only one. I don't know if you guys know any other person who is doing detoxification for glyphosate, but he's the only one I know has a product called Glypho Detox that cleans up the glyphosate.
What was the name of that?
Doctor, it's on econugenics.com if you go
Okay.
there.
Can you put it in the chat there, Dr. Tano?
Yeah, econugenix.com.
Can we have all of them on the first one from Pure Encapsulation?
Pure encapsulation has the HM complex and the detox pure pack.
So I like to start them off with a multivitamin especially before doing a heavy metal detox.
Right.
I mean, you can get fancy and measure their micronutrients and their amino acids and rebalanced out. But I probably only do that with somebody who is a little fragile, to make sure that I'm supplementing them properly before I gently detox them. And the heavy metal product, I'll look that up, but what I've been using is either Chelex by starts with a Z, Zymogen, X, I mean, starts with an X, by Zymogen, which is a nice gentle way to remove heavy metals. And then there's a product by Detoximin, which is an IR, so it's an interrectal suppository. Again, you can do it pulsing and try to make it, and they come in, I think it's in 500, 750, and 1,000 milligrams, so you can actually use it for children if you
Is
want.
that EDTA?
Yeah. Yep, so is Chelex, CDTA. Yeah.
And did you see reduction in the heavy metal, Miss Dr. Cherna?
Yeah. Yes, that's the way I like to do it. I don't prefer not to do the IV chelation.
Mhm.
You know, that area of our bodies is highly absorptive. It also allows the levels of those, I mean, both oral and interrectal allow the levels of the EDTA to remain longer in our bodies so that it allows us to more slowly take it out rather than just have this high peak of the chemicals from for the chelation, in an IV.
No, that's a great point because doing the IV chelation, like you said, it's rapid and then
Yeah,
there's recirculation. But if you do the
right.
suppository, you get some of the metals out before they recirculate.
Right. And then, of course, it's always about supporting, the emptying of the gut, the whole healthy
Of course.
moving of the gut to actually help them get it out of them. Yeah.
Right.
These are really important things to do.
So
For
I
all,
always say when the patient come, I have a routine. I give
yeah.
them a multivitamin.
Yeah.
I give them an omega-3.
Yep.
I give them vitamin D3 with K2 in it.
Yep. That's exactly what I do.
I give them magnesium.
Uh,
I give them also vitamin C
okay.
because
I give them a
studies,
probiotic too.
I
What's
give
the
them, it depends. If they have abdominal problem like IBS type of problem, then I give them a probiotic, prebiotic, and digestive enzymes.
That's a lot. Yeah.
Those
I just think
three.
there's pill fatigue though that I'm
Yeah,
trying to be
there.
wary of.
But many
what's
people,
your dose of vitamin C, Dr. Tano?
oh, vitamin C, I give them 3,000 milligrams, which are 3 gram. Or if they have constipation, I tell them, hey, you can go up on it. You can do even 5 grams if you want to, but you have to do magnesium citrate with it. And if you did
Right.
that in the morning, then by 10 o'clock, many of them will go. So they become regular. They come back and say, wow, I didn't know vitamin C can do such a great job instead of all the laxatives and everything else.
So there's a difference, our vitamin C lady that we had on between ascorbate and ascorbic acid.
Right.
Correct. Yes.
So, all right. I think the ascorbic acid has a lot of the more GI symptoms.
Right. So there's buffered ascorbic acid that I use from Pure, and that has proven to be great. But they
Yeah.
also have the vitamin C, but I don't use the vitamin C. I use the buffered one, which is more GI tolerant.
So I'll tell you why I don't do it that way. So it's part of the discussion. I mean, as valuable as vitamin C is, I think that like a beginning patient, I have my routine as a multivitamin,
Right.
probiotic, vitamin D, and omegas. And then the probiotic will help the bowel function, whereas magnesium citrate works by irritating the gut. So I'd rather, get a lot more with one stone with a probiotic.
Yeah.
Mm.
So
I might do it.
the magnesium, my go-to is magnesium threonate. But if they're having constipation and they're trying and they're not
Yeah,
doing well, then I double up and give them a little bit magnesium citrate with
yeah,
the vitamin C, the buffered, not vitamin C, but buffered ascorbic acid, and they do much better with
yeah.
that.
I do that later. I just think that that's sort of more the cherry on the top and a lot of, so magnesium's big. And so it's, I worry about pill fatigue, especially with a new patient because it's new and it's different and they can't always go home and talk to other people in their lives that are doing the same thing. So I try to, yeah, so if they need magnesium, which we all do need, I encourage them to take an Epsom salt bath.
Okay, well, because magnesium deficiency being such a big deal
I know
in
it
the
is.
whole country,
Yeah,
and they get aches and pains and stuff
I
because
agree.
of getting
Yeah,
palpitation. You
yeah,
don't know. So that's why I personally give them magnesium threonate, which is not going to cause, if they're regular but not having constipation, or if they
yeah.
have diarrhea and all of that, I give them magnesium threonate,
I'll have to
which
look that one up.
seems to be better than the other ones in terms of the gut tolerance.
Okay,
Que-
I'll have to look
Question
that one
about
up.
how much magnesium do you use?
I give them like I mean I don't can I give them the pure encapsulation ones. I give them three, like magnesium threonate. I say take three. It says take two, the serving size, two at bedtime. I say take two or three at bedtime. And many of them come back and say, well, since I've been doing that, actually my joints are much better. I don't have much of achy stuff, and it does help them. So.
Okay.
Yeah, so there's an important point to make about magnesium also is that if your patients are not using professional supplements, um, and it could be used as a motivating factor too. Like, so if they look at the label and you say, okay, I want you to have 500 milligrams of calcium, I'm sorry, magnesium, whatever form you want, and they go to the store and they buy it and it says, magnesium carbonate or taurate or whatever,
Oxide or
500 milligrams or glycinate or whatever is on the bottle, it means that like it's 500 milligrams of that entire molecule. Whereas if you encourage them to use the professional stuff, it'll say magnesium, whatever, magnesium glycinate or carbonate or taurate or whatever. But then in parentheses, it'll say the form that it's in. So like magnesium. So if I want them to have 500 milligrams of magnesium in the glycinate form, the bottle should say magnesium and in parentheses say glycinate and then 500 milligrams. That way you know the patient's actually getting 500 milligrams of
yeah,
the
so
magnesium.
like pure encapsulation, we say, well, they don't put fillers or shellacs or binders in
Right.
the supplements. It's
Yeah.
hypoallergenic. So you know that whatever amount they say you're getting is approximately what you're getting.
Yeah.
And that's
Pure
why
encapsulations is great, but when they got bought out by Nestle,
they don't have any difference, by the way. Actually, Nestle doubled down and they probably quality-wise, they're better than before.
that's hard to
Yeah,
imagine.
actually, yeah, true. Because
They do keep it
I,
separate, but it
yeah.
just worries me.
I don't work for them, but I know for
Oh,
sure
yeah, I don't trust them as
they
much.
they they are they doing a good job because they still have doctors on board for their formulation. It's not like we have lay people doing it, so they didn't fire all their
Well, it's
crew.
just where they're sourcing it that concerns me.
Oh,
And
but so that's why they run out of the time because they check. They want to live up to their name pure. They don't want to give you
yeah.
toxic things from China or anything like that. They check, recheck, and if it's no good, they return it. Currently, if you go there, try to buy the Cognimag, which is the magnesium threonate, basically they run out all the time because they don't have it.
Okay, well, I have to
Yeah.
look closer at them because they have a lot of great synergy. They have a lot of products that have great synergy in them that I don't see in other
And
companies.
by the way, everybody copies them. If you take Metagenics,
Yeah,
you take Zamogen, you take
yep.
everybody, they copy them. So we better than Pure, or they copied them.
Yeah.
So I
No,
wonder.
it was a great company. I'm just wary of them now. So how long is the detox? So I encourage them to do it at least for 2 weeks. And then as a kind of maintenance, I encourage them to do 2 weeks twice a year or 1 month once a year of the core restore detox,
Right.
just as a maintenance. That's what I do. The heavy metal stuff needs to be monitored, and adjusted depending on how they feel, how well they are.
Mhm.
I see. Thank you, doctor. Um, wow, it's amazing. Yeah, that's very good. Do you use modified cytospectin, zeolite?
Oh, Chelex has that in it. Has zeolite and a couple other things I can't think of off the top of my head. It's
Yeah, I saw Chilex all the time, but I never used it from Zamogen, right?
yeah,
Yeah, I never used them, but I know of that.
yeah, pretty simple to take too. So yeah.
Yeah.
And then I'll add binders too. That's a separate product. It's charcoal but I separate that, the Chelex um, with the other binders. I have to like double check myself here, but I use the two products. And I use the binders like if they have die-off symptoms, like um, if they're doing a detox of any sort and they have die-off, the binders can really help them.
Mhm.
I'm trying to remember what company that was. It's a black bottle. So yeah, I like Chelex. I like oral stuff for detox. I think it's safer than IV. And I think
And
it works better.
do you use glutathione or an acetylcysteine? Because they said that.
Glutathione, I think, is overrated. It's really hard to cross the blood-brain barrier. And I don't find that like the the special ones that have
It does not crosses
lipo.
the
I don't think,
blood-brain.
but NAC, yes, definitely NAC is a precursor for glutathione, yes. But
Mhm.
I have in the past used or prescribed glutathione. Was it liposomal or whatever? It's supposed to cross the blood-brain barrier. Yeah, that's a Quicksilver Scientific Ultra Binder. I use that for like symptoms of die-off. And they just start feeling nauseated. They got a little headache, and they just don't feel that their energy drops, and that works better, I think, than the glutathione. But I like everybody to be on NAC, right? Like we all use that.
And what is the max dose?
Except if they have a gliotoxin, right? Did you attend Dr. Kimball's lecture?
A
And
what
he said
toxin?
gliotoxin. So if they have a more toxin and they have gliotoxin that comes up positive,
Oh, I don't do
you
that.
don't want to give them NAC because
Oh, I
apparently
don't know that.
makes it worse. So people,
Gliotoxin? How do you,
yeah,
is it,
gliotoxin is
how do you test for that?
they do the blood test. Is my Myco lab. That's Dr. Campbell who did a presentation on this forum here.
Okay.
So if you go to
Oh,
mycolab.com,
mycotoxin. Sorry.
yeah, mycotoxin,
Um,
so mycolab.com,
okay.
Dr. Campbell, what's his first name, Dr.
Andrew.
Clearfield?
Andrew.
Andrew Campbell. He came here and then did a beautiful presentation. So I
Oh,
use
okay.
that lab now to test for mycotoxin because that's the only blood test that exists. And
Okay.
according to him, the urine test is false, it's no good.
Ah,
So
okay. Okay. Yeah, I've been using urine tests for mycotoxins. Um,
Dr. Nario, is there anybody online have any questions? You've been very
It's
quiet.
They're pretty convinced about this argument. Let me put my 2 cents in here. So I also stand on the side of using estrogen. So as again, I'm citing WHI here, which is the debunked. I guess we're so angry about study that even there they were citing that even Premarin, the conjugated estrogens, equine estrogens, have been noted to be protective for breast cancer. And you have to remember that the study also was pertaining to progestins or progestogen that actually are the stimulants of the cancer growths. And another thing where the tide is kind of swaying over to our side of the use of estrogen is of course the removal of the FDA warnings or the black box warnings of specific hormones now in the market. But again, in this field where I am, I've experienced so many lectures and students' questions and even interaction faculty that there's so many stands about using hormones. The thing here is nobody's wrong. The only important thing that we have to remember here as practitioners is, are we helping our patients? Right? It's always about the benefit. May your I guess approach be just pure progesterone, avoiding estrogens, removing xenoestrogens out of the system. It's really all about the outcome of the patient. And you would notice that every practitioner who shared their experience here in this platform are so different. And you're scratching your head like, how could that even work? It works, and that's the thing. That's the magic of individualized medicine. So there, for me, I think there's nobody that's wrong here, unless you did something harmful to your patient, and that's when you question yourself. But again, everybody's point and perspective of this platform is great, and this is a very good discussion. And I think the questions have been answered and squashed as you guys discussed it very thoroughly.
Thank you. That's great.
Well, I don't have
I
anything
agree.
to
Thank
add.
you. This is Dr. Barbie Barrett from Stanford.
Mhm.
Don't like to say it given
Oh,
that
Dr. Barrett,
study.
hi.
Hey, hi, how you doing? Good to see you. And I really love that everybody's contributing and, different points of view, and the attitude of nobody's wrong. We're all trying to do our best for the patients. However, Dr. Tano, you have been kind enough to throw down the gauntlet and give the challenge to me. I am an elderly female, and I have no intention of being deprived of my hormones, unless you can give me some better arguments. And I do not deprive any of my females. I have a 90-year-old female on hormones, and she is very happy with that. She was not happy prior to that. So I've got to go now because I've got a Zoom conference with the patient. But everybody, you've been great, totally helpful. Thank you.
Thank you.
And I will accept your challenge, doctor.
Thank
Oh,
you.
I actually give hormones. I give progesterone, DHEA, all of that.
That's
I'm not
great, but I want more.
Yeah, I'm not anti-hormone. I give them what they need.
I give them what they need and I test them. So I got to run.
test
Sorry,
them.
sorry guys,
Exactly.
but thank you so much.
Dr.
You guys are
Barry,
fabulous.
we're gonna get you in here. We want you to
Yep.
lecture in our platform, okay?
Sounds perfect. And
Okay.
thank you, everybody. Bye.
right.
Bye.
Bye. So Dr. Nario, the next question I have is, she said she was an elderly female. Define elderly.
Over 30,
Well, she's
maybe.
not here anymore. That's a good question.
Well, I waited till she left. So
I know her personally, so I'll run after her to bring her over here to
Okay.
our
all
show.
right, please do.
She's a faculty of A4M too.
Okay. So so what do you have coming up this weekend?
I'll be flying to Florida, Clearwater, this coming Thursday. We'll be having lectures from Friday to Saturday, all throughout the day for Module 5. But Spring Fest, Longevity Fest is going to be there. Be there, be square. Do stuff, good stuff.
And if you
It's
can't
a
make
West-
that, you
it's
come
a
the
West
next
Palm
weekend
Beach,
to
right?
I'm sorry,
AMMG
go ahead.
or AMMG's at the Royal National Golf Club, April 15th to the 19th. And I will be doing, they gave me, as part of the introduction to bioidentical hormones for beginners, I'm doing thyroid, cortisol, insulin, endocrine disruptors, and laboratory all in 1 hour.
Wow.
So let's
You're
just
the best
say,
person for that.
let's just say it's a brief skim. And then on Sunday I'm doing laboratory of functional medicine part 2, and I'm doing saliva and part urine. So
He's
those
the
of you
best man for the job.
don't like it, don't listen. That's all.
So
And
go to Florida. Don't be leaving for 2 weeks.
yeah,
Sounds like
and I don't know that I told you that I was invited by IFM to their international
San Diego.
conference
Yeah.
in San Diego, and I'm doing the endocrinology of psychiatric illness. So we'll be talking about mental
Ooh, I
health.
love that. That's
All right,
great.
represent.
So
Yeah.
we're moving up in the world here.
Yeah.
So
Yeah, and I also love that genetic test I mentioned to you
mhm,
for psychiatric care.
mhm.
Really help choose which med to give the patient. Gentle mind.
Okay. All right.
That's-
Anybody else have anything to add? We're after 10:15 back east. So So thank you, Jeanette. Well,
Yeah, you're welcome.
thank you, Dr. Tano, as always. Dr. Berkson out there, thank you so much for your cameo appearance. Dr. Tano, of course, is the brains of the group. Dr. Quinn for the research group. Joel for being my right-hand man, and of course, Dr. Nario, and everybody else for being here. I know there's a couple of new people here. We met them over the weekend. There was a women's showcase in Reno this weekend, and I met a couple of new practitioners, and I saw one or two of them on here. So thank you for coming, and don't be a stranger. So this Saturday, Joel and I will be at the Atlantis for the endocrinology for non-endocrinologists, and we're not speaking. Nobody invited us to come talk, so I'm sure
Don't break legs there.
I'm sure it's going to be. I'm sure you'll be steam coming out of my ears by 8:30 in the morning.
Just watch.
I'll keep them
watch.
calm. I'll
Okay?
keep them calm.
You're not going to be around, are you, Dr. Nario?
No, I'll be in Florida. I'll be there in spirit.
How much you want to bet he speaks up within the first hour? I'm just saying.
So those of you who've heard one of my thyroid lectures, so this is what I'm expecting. If the TSH is greater than 10, give them Synthroid. If it's 4.5 to 10 and they have symptoms, give them Synthroid. If it's under 4.5, they're crazy. Send them home. Diet doesn't matter, and yeah, you can measure the thyroid antibodies, but there's nothing you can do about it. Okay, lecture's over. Thyroid.
Well, you can measure the thyroid antibody that you can do a lot about it.
There's nothing. No. The endocrinologist. There's nothing you can do about it.
Oh, you have endocrinologist. Yes,
that's what I'm just saying. I'm going to the.
Of course, the endocrinologist. Yes.
How crazy is that?
Endocrinologist of northern Nevada.
So you have to make them. You have to tell them what they want to hear, right?
They're not fans of myself. My name in their circles is Mud. So.
Yeah.
So
gonna put a bullseye on your forehead by going there.
So I'll try to go in incognito. I'll wear a baseball hat.
I'm gonna take as many pictures as possible.
Like Dr. Klatz, Dr. Klatz shows up with a baseball cap. Nobody knows who he is, right?
Oh, that's funny. He's a big guy though, so he's hard to hide.
So yeah. So anybody else? Janetta, you're in Reno, so if you have nothing to do on Saturday, you
I think it'll be fun.
Join our.
Because I've always been fascinated by the way.
How much was it? Was it $46 or something? It wasn't that
No,
much.
I think it was 24. I think it was $46.
$24. It was 46 for the two, 48 for the two of us. So it was
might be cheaper for nurses, just saying.
Yeah,
right.
Probably
sometimes it is. But yeah, no, that sounds fun because I've never really heard them speak as a group.
Right.
And they are such a force that works against what we're doing. It's really wild that the system has managed to capture, the people who are supposed to be experts in the field. And I don't know of any one endocrinologist that thinks outside of their box.
Well, think about the VA. I'm dealing with this right now. I wanted to talk to him about acupuncture and chiropractic in conjunction with my physical therapist. And they're like, no, we can't do that. So they only let the primary care do one modality at a time. And they said, how do we know what works? And I told them, and I quote, because I'm the patient. I'll tell you if you're fixing my left wrist. I'm telling you if you're fixing my neck. I'll tell you if you're fixing some of my neuropathy. I'll tell you if you're fixing my... They won't do that. They only go one at a time. And the one at a time could be anywhere from 8 to 12 visits within a 6-month period. So you've got to finish those 6-month period. And a lot of us stretch them out weekly so we can go as long as possible. So you're talking years and years. It's ridiculous. It's pathetic, but
they're not going anywhere. They're not there for you.
No,
they're not there for you. They're there to get a pension. Don't you know this by now?
Well, they're the largest medical system in the United States. So when we talk about big pharma, we're talking about the VA.
I didn't know that. Yeah, my father was a veteran. He was an Air Force flight surgeon. So my mom would talk about the VA with us.
It's rough.
And what crazy things that they've done to people.
All right. So
yeah, that's tough.
let anybody send me some questions to ask the endocrinologist. So we're going into the lion's den this weekend.
Yes, we are. This could be
I'll
fun.
just bring my pom-poms for you.
I'm looking forward to it. So, and oh, by the way, and if you do corner them on it, say, kind of corner them, their fallback answer is, I said so because I'm a board certified endocrinologist. That's the fallback answer.
Wow.
Which means that's my standard of care, and I'm in this box that I can't get out of, right?
Right.
That's when they claim
Well,
that.
it's not that they can't get out; they don't want to.
No. Sure.
They literally. I mean, everyone that I've dealt with, they literally do not want to.
No.
Well,
Yeah, I really think, Dr. Bill, one of the things that they don't measure anything about free T3, reverse T3, none of
absolutely
that.
not.
They don't go there. And I wondered, what is the holdback? You want to ask them that question. Why don't you guys measure these things? You give them Synthroid, you give them levothyroxine, or even Tyrosint, and yet you don't know where this is going. Are you happy with it?
You just
in
answered
their
your question.
defense,
that.
it's hard to measure T3. Whatever's running around the blood is not really a measure of what's in the body.
They
But
don't want to fix it.
I'm
They
not
want to give
meaning
you
to
the
disagree with you, but just saying that that's one of the defenses that they could come up with.
they want to give us the pills.
No, well, the answer is usually it's unstable. That's
Yeah.
Wow.
It's unstable.
Unstable.
Yes.
So it's food. Food's unstable.
Well, that's what I said. Did you have dinner last night?
Right, exactly.
You gonna have dinner tonight?
Yeah, yeah.
Why? You had dinner last night.
Hey, if it's stable, it's probably not good because we can't use it so easily.
Right.
But
Yeah, I got somebody now so dinging me because I gave somebody some T3. So of course that caused the an 85-year-old lady. Now she's got osteoporosis, and of course it was from the T3, right?
well, do a liver panel on her and see if AST should be high if that's true, right?
So,
Well,
again, so I asked. I said, well, ask the endocrinologist what does the thyroid make? What molecules does the thyroid make?
But they prescribe Cytomel, right?
A few of them will, yeah, but no, but that. Yeah,
you had to fail T4 before they give it to you, but I didn't think it was all that uncommon to give Cytomel.
No, it was liothianine, and it that caused the osteoporosis.
Oh, okay.
Yeah.
Well, you're a bad doctor doing that.
I'm the worst. I'm the worst.
Yeah. Well, you're in good company.
Hey, we've been leading this group. This is the worst group.
I'm so glad to be in this group.
Amen.
Sad practitioners, man.
The best group ever.
Searching for since I've been here. I heard about it through the rumor mill.
Yeah, we're the absolute worst. So,
love it.
And we're proud of it too.
Yeah.
That's right.
Yeah. But wary, right? Like it's not good that they can still make it really hard for us to function.
Yeah.
Well, we kind of thrive on that actually. So.
Well, that's good. Then maybe some of that will rub off on me.
I had a little. I have to admit, I had a little slump after the AOA threw us out, but I think we've gotten over that.
Yeah.
So.
It was hard to watch.
Yeah. Well, and it's not just because I imagine it's not just because it's happening to you personally, but it's such a failure of trust. What's the word? It's such a this is such a huge organization that people trust their lives to.
If you go back, it's on YouTube. If you go back to July 2022, there's the video of me in front of the House of Delegates.
Really? Well, you got to send this to me.
It's on YouTube, July 2022, and it's a little hard to hear because the filmer was way in the back and I was up front, pleading our case, and I did such a good job. It was the vote was 530 to 1 to throw us out.
Up to 542 to 1, I think, or something like that.
Yeah.
Hey, we're making funny and talking about years ago, but it was only last month I had my license taken by the Medical Board of West Virginia.
Yeah, what happened with that?
Oh my
No,
gosh.
my license is gone. They took it. They declared me a threat to society and
Oh,
mentally ill.
It
Now
took them
that's
40,
oh
the
my gosh.
it took
yeah,
them 40 years to figure that out.
yeah.
I knew that
So
the
now
first day I met you,
no,
John.
it's not funny really,
I
and
know.
we have a major
Yeah.
legal action going on because just because of believing the same thing we all believe in, which is the truth, I hope,
Yes.
and anything related to natural medicine. For those reasons, I was declared mentally ill, and my license was revoked after a perfect record of 45 years.
Oh my
So,
gosh.
so Jeanette, I don't know why I know you take it seriously for some reason. And maybe that was your daddy who was, or who was it, the test pilot or the
Air Force
aerospace?
flight surgeon was my dad, and his father was a physician also. But
So,
for me, what it is I think in the 80s, I remember when they started accepting non-science majors to medical schools. And my feeling is that that's when we lost our base footing for what the truth is. And
Right.
I think that, I mean, I had my own personal crisis that led me into this field, but it was the biology degree I have that, and I love all that stuff. And that what's really held my act together was like, I can't deny the truth of this stuff.
That's right.
It's just indelibly true. And so yeah, so that's how I, held my own through this whole, or held my act together going through this, because I felt incredibly lonely, professionally and personally, because I still can't explain to my own siblings what did I do. Because, my God, they go out of control, crazy, and say horrible things about me. Um, but I think that that's one of the reasons why, like that they can get away with this crap. My father and my grandfather both have, hardcore science degrees. My father has a chemistry degree, and like my own brother, who's an aerospace engineer, will say that, Dad would give you a hard time if you're saying this stuff. And I'm like, Daddy knew me, and I know he would love this stuff
That's right.
because it's undeniable. And that's why these arguments you have with people, like, I don't think they could hold their own in a truly scientific, basic physiology
hey,
conversation about what you're doing.
for what it's worth, I did flight surgeon for 11 years. I was also a tactical military pilot. I went through the secret programs. And what you find out, and that was in the mid 70s, man, I'm seriously old. So by the
Not as old as my
1990,
father.
so by the 1990s, and it was in the news last week about the SEER program that saved the pilot, right, who went down. But
Oh
the
yeah, I
same
love that
in
conversation. That
that
was great.
program, and that's 50 years old. But the most advanced, energetic, and electromagnetic microwave mental control programs are the United States government. They had it down to a science in the 90s. So I have no idea what's going on now, but when
Right.
it's going to be released. And
Yeah.
the anti-gravity propulsion systems, that's old shit. And but the free energy, that will probably be released
Right.
soon. Yeah. So anyway, I'll
Well,
keep
you
my
let
mouth
us know
shut.
what it is. You'll let
Yeah.
us know what it is.
Yeah.
Yep.
But I can tell you no stuff. That's why I couldn't help but jump in.
Yeah, it's great.
Let us
It's,
know
I'm
what we
thinking.
can do to
And
help
that
you, John.
workers, I just want to say,
Ah,
they,
do it.
what was the reason they said that they to take a license? That's so scary.
No, I'm one of the lucky ones. I'm alive. Do you guys remember when we had like 100 doctors die
Yeah.
unexpectedly?
Yeah.
Yep.
Okay. So it's better than it was 10 years ago
It was
because they were
over 150, actually.
yeah, what was that, 10, 15, 20 years ago? I don't know. So I feel lucky to be alive. I try to stay under the radar,
too.
but being honest and open the way all of you are, um, that's a risky thing to do, and we have to face it. And now that we have all of these wonderful people working things out and doing the research, so
Mhm.
there's no question about it
Right,
at
right.
the high. So we have the highest minds at the highest level doing the finest research, I think, that is possible. And that all comes from this group.
Amen.
You let us know what we can do to help you, John.
Yeah, man. Just do what you're doing, man.
Okay.
Appreciate it.
Well, I'm starting to look at PhD programs in clinical research because I think that that's what you're leading it towards. It's research that's undeniable that will protect this whole.
Please get in touch with me or Dr. Quinn. He's heading that program, but please get in touch with us. Dr. Tano is Mr. Wonderful creating stuff, but he's created a software program and applications will be developed that will allow us to do this research.
Oh,
So
wow.
Dr. Tano made our work 90, 100 times easier. It's
Okay.
amazing what he's done. So we can gather data via
Yeah.
his applications via cell phone. So it costs the university nothing, the medical school nothing. He's figured this stuff out. And then we can gather and sort data, but we need minds like yours to make it ethical because that's the name of our group is Ethical Research Group.
Well, isn't that what it's all about?
That's
Is being
all about
ethical, like
ethical,
using
all
this
about,
information for ethical and moral reasons? I mean,
yes.
why else are we doing it?
That's why we're doing it.
You
Should
know,
be. And so we have some really super smart minds in this thing. And we would love for you to join us and help us with that because
can you
that's
send
going to,
me
Fun too. I would
information
like
about
to-
it?
yes, I'll send you
Definitely,
lots of information. We'll have fun.
Awesome. Love it. Love it. Love
Thank
it.
you.
Okay,
Yeah, exciting.
anybody else? We're coming up here. Okay. So next week I have a very pleasant young lady. She's 20 or 21, a patient. This is going to be another patient case. And she's got just about every autoimmune disease you can think of.
Oh, wow.
And so I'm at a bit of an impasse. She came to me after going to the Lyme doctors and the who else is around here? The orthomolecular doctors and the all of that stuff. And so she's got the Hashimoto's disease. She's got the positive ANA. She's got positive Sjogren's. She's got positive, you name it, it's positive. She's got food sensitive. I did 184 panel food sensitivity test. 120 of them are positive. And a lot of them are not just, a little bit positive. They're highly positive. So I'm a little bit of a loss, and she agreed to come on. So I'd say, we got a lot of minds here. We'll present her. She's very pleasant, and it's really a shame. And if we can sort of come up with a plan for her, I think that
Love that.
Well,
Love doing that. I bet the answer's in her history.
So
What about the young girl who 10-year-old you said had polycystic ovaries that was going to be presented? I think, did I get that wrong?
we did a case a couple of weeks ago. Were you not here?
Yeah, where she was 25 at the time and
Oh yeah.
There was a
she had a
10-year-old.
trauma
actually-
happen to her.
Actually, she's actually doing quite well. Okay.
Oh, good.
Yeah. I mean, her periods are regular now. She's having a lot less pain. And as long as she sort of behaves herself and does what follows the diet that we gave her and exercises and gets enough sleep, she seems to be doing she's doing quite well. So I'll
Did you
give
give her progesterone more often?
yeah, I'll give you an update on her
Yeah.
next time I see her. Okay, so I'll probably see her probably in the
great.
next 4 to 6 weeks. So okay,
I would say that like for the patient next week, I would my first hunch is that the answer's in her history.
of
So I
course.
don't know how
Of course.
Well, I don't know if she's
go back to
because
doctoring 101. Of course it's in the history.
well, I just want to like prepare her that
Right. Yeah, no,
that
she
would
knows.
be a good place to start so she can kind of pre-think it already because
Yeah.
it's a lot.
Yeah, she knows. I'll
Okay.
have her ready. So
Right.
hopefully, I just don't want to scare her off. She's pretty young.
Yeah, we'll try not to attack her with
She's
questions.
been through a lot. So that's next week. Okay.
Sounds good.
I promised to have Dr. Well, he's not doctor either. So I promised to have Stefan on to how to present his family practice model. So I have it for May 12th. So I know we put him off a little bit, but he will be on.
Yeah, it'll be interesting to know how many of us have cash practices and how many still try to work within the insurance model.
So
I've never been in the insurance model.
You're lucky.
They don't really know me.
You're not missing anything.
Oh, that's cool to me. So I don't know. Yeah, it's
Yeah, you're
a
not missing
fortunate
it.
thing.
You're
Very
not
good.
missing it.
That's
Yeah.
You know, as soon as you sign up in an insurance model, you're already a thief and a liar and a crook and whatever.
Yeah.
I even opted out of Medicare right away.
Right. So we've
So
been
I
out
don't
of
even know.
we've been out of we haven't taken any insurance since 2020. And just last week I got a letter from some Blue Cross in Northern California that we were overpaid $63 and they want a refund.
Wow.
What are you talking about?
Wow, I could think of something really nasty to do back, like put $63 in cash and wrap it in something stinky and mail it back to them or something.
Yeah, well, the
I'm
problem is
just kidding.
if you do something like that, some of them actually have these hidden clauses that now you've agreed to be in their network and you're stuck.
Oh, wow. Oh, wow.
Yeah,
Wow.
you have to be really careful about those
Wow.
kinds of things. Every once in a while, we'll get a check from someone that, one of the patients will send it in and it'll come to us and we won't cash them. We send them right back.
Wow.
And
Yeah,
so
I do use everybody's insurance
because
to the max I
we tried,
can.
we had a patient had we did pellets on somebody and the patient sent in the super bill and they sent us money in my name and
Oh,
we called them and said that we don't accept this and they said, well, just endorse it over to the patient. And then it was a Blue Cross, then they tried to say we were in the network because we cashed that check. So,
wow. You should give it to somebody else. Wow.
That's
Wow.
tricky.
yeah, so you need to be careful there because they're gung ho on Medicare fraud, and even if you've never even if you don't take it, you get these letters.
How about the bill I just got today, Doc?
Oh yeah,
The VA sent me to a nursing home for 3 weeks. That was when I was in a wheelchair, and now I've gotten a bill, and I'm 100% permanent total, lifetime, and it was $11,800, saying they're not going to pay it, and they sent me there. So I'm gonna fight it. I'm gonna work with it, but that's the type of stuff our vets are going through. It's
My
ridiculous.
dad was a vet also.
Yeah,
Yeah, and he was 100% disabled.
yep.
So, yeah.
They get so many vaccines, the vets.
That too. Yeah. And then the chemicals.
Yeah.
Everybody hears about Agent Orange, but they don't hear about Agent Black. That was sprayed most. Then you got blue, you have gray, I believe you have violet. That's why they called them
Wow.
colors, because they did the colors of the rainbow.
Wow.
Yeah,
Oh,
so
yeah.
it's pretty deep.
Wow.
He didn't want any one color to be dominant. You have
That's right.
Yeah, I have a neighbor
had to
who
be
is a
equal
veteran.
opportunity.
I have a neighbor who's a veteran, and I mean, I'm friends with his wife, and their first child has some type of dwarfism. I don't remember what kind,
Right.
and they don't have it in their own genes. So, like, they tested the parents, and neither one of them have it in their genes. And the physician said it was from whatever the heck he was exposed to.
Yeah.
And then they have a daughter also, and she's recessive for it, so she looks like a normal height and all, but she has the recessive gene for it.
Garth Nicholson was one of the main proponents for cross contamination into family members, and he was the one that
God.
he proposes the phospholipids and phosphatidylserosines and all those, and bio that Doc has. I forget the name. It's a powerful
Wow.
supplement that we use for our quote unquote golf vets.
Which one was it?
The bio phospholipids. There's 4 of them.
It's omega-3, omega-6 fatty acids with phosphatidylserine and phosphatidylcholine.
As treatment, you're saying?
And phospholipids. Yeah. There's like 4 of them in there. Yeah.
To like what help preserve the cellular membrane so that it
I
doesn't
believe so.
Yep.
get.
Yeah.
And
It just reminds me about how like Lyme disease can be an STD.
Right.
It just really, we're up there.
Lyme disease can be an STD.
Yeah. Yeah, and they have a documented case of a woman who had Lyme disease. I suppose it was chronic at that point. And her baby was born with it. Like they tested the baby, like they were in the waiting, they were in the delivery room, to watch this child be born, and then they drew blood on it and it was positive. So yeah, it's a bioweapon. It's scary.
Yep.
And I grew up in New Jersey, so and my parents loved to go out in the woods. So
New Jersey. Oh, I'm in New Jersey.
oh, where? What city? Oh, you're in New Jersey.
Hillsboro, New Jersey.
Hillsboro. That's a nice area. Yeah, I grew up in Jersey City. My two Dr. Cernas had their practice in downtown Jersey City, my father and his father.
Wow.
Yeah, so hey, I'll just tell you one more thing. I know it's like super late, but my grandfather, Pedro Cerna, was born and raised in Nicaragua, and the government of Nicaragua sent him to the US to get his medical license, and to become a medical degree. He had to come over here and start off with learning the English language. But he was the eldest of the eldest of the eldest, and he brought him and his 15 siblings and his parents back into this country.
Wow.
Yeah, so he was actually the personal physician for the president of Nicaragua at the time.
Wow.
Nice.
Yeah, yeah, it's pretty interesting history.
You're
But apparently there's a
no,
Cerna that is a horrible torturer. And I'm not sure what the connection is, but
There's always one in the
You can
family.
disown that one.
I've gotten pulled over in security. Like I'm thoroughly searched 15 times with my little kids and I think it's because of that name.
Wow.
But yeah, I hope he's not related to me because the Nicaraguan cousins they have, they're distant. We're all out of there. They say there's no records; they're all been burned. So who knows what the connection is? He's still alive, this guy. I can't remember his first name. Anyway, that's
Okay.
brave physicians.
Okay. All right, we're good. We'll have the video up when it's ready, probably not till tomorrow because it's late. I'll send you the contact information, Jeanette, if you want it, and Dr. Chano also, and anybody else.
For the group.
Yeah. The video
Yeah.
will be on aosrd.org and also on YouTube on Clearfield Medical Group. So
Okay, great. And I'll look up the Saturday event. I'd love to go and listen to them.
okay. All right. So
All right.
give us
Have a
a
good night, everybody. That was
Joel's the one
fun.
who found it. So
Thank you, everyone.
okay. Good night, everybody. Thank you
Hey,
all
good night.
for being
I
here.
keep an eye out.